All right, everyone. Thank you. Welcome to the October 15th, 2025 Licensing Committee meeting. My name is Song Oh, chairperson of the committee. We have a lot going on. This is kind of big news in pharmacy world. A couple legislations being signed in the last couple weeks. Very excited. Pretty monumental day in a moment. So we have a lot to cover. Our meeting could take probably all day, or it could take 4 hours, depending on how much conversation we have today. So just wanted to give heads up for planning purposes. I'm gonna most likely guess we'll have to take a lunch. I do not think that we'll be able to wrap up all this by 1 or 2. So I'm pretty sure we're gonna have to take a lunch break, and this may go on for a long time. So please keep me posted if you have to depart for whatever reasons to our members and to the public. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 3 minutes to each individual providing comments. We'll begin with public comments for individuals attending in person, followed by public comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions on the process for providing public comment via WebEx. Moderator, Sarah?
All right, this is the moderator. When public comment is requested, I will ask for public comment first in the room and then on WebEx. If you would like to make a public comment, you can click the raise hand icon on your WebEx screen, or if you're an audio-only participant, you can press *3 on your device to request public comment. When we get to you, you'll be given 3 minutes to speak with a 10-second warning, and at the end of your public comment, you will be muted and we will move on to the next individual who has public comment. And I believe that's it for my instructions.
Thank you, Sarah. I feel like from my memory, the instruction used to be so much longer. It's gotten so short. I love it. I'd like to take a roll call to establish a quorum. Trevor Chandler?
Present.
Thank you. Our Vice Chair Trevor Chandler's here. Renee Barker?
Good morning and present.
Thank you, Renee. Jesse Crawley, I do not believe Jesse's joining today. Satinder Sandhu.
Present.
Good morning, Satinder. Claudia Mercado.
Present.
Good morning, Claudia. And I am here. So we are, our magic number today is 4, so we have to have 4 members to continue to, proceed. But as a quorum has been established for today, members, we have a full agenda for our meeting. I ask everyone participating today to be respectful of the work before the committee today. We encourage participation by members of the public throughout our meetings at appropriate times. The committee respectfully requests that when comments are provided, they're done so in a professional manner, consistent with how the committee conducts its business. And before we move to the next agenda item, I would also like to remind our members, committee members participating via WebEx, to please remain visible on camera throughout the open portion of today's meeting. If you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off the camera. And finally, I would like to ask staff to send out a link to all members when the live stream of the meeting is available. This will ensure members that are interested to have an opportunity to review the meeting prior to the next board meeting. We're going to have a lot to discuss today again, so just giving the heads up, and looking forward to our very fruitful discussion, lots of presentations, and really big things today. Next is agenda item 2, public comment on items not on the agenda items for future meetings. I will now ask the moderator to open the line for individuals to provide the opportunity for public comment on items not on the agenda. You're not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take any action on the items except to decide whether to place an item on a future agenda. Accordingly, if your comment pertains to an item on today's agenda, please save your comments for the public comment period specific to that agendized item. Members, following review of the public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Do we have any public comment in Sacramento? I think Dr. Kim is the only person in there, and I see he is walking up to the microphone. Be careful, Dr. Kim. We have a lot of items agendized for the day, so just keep that in mind, please. Thank you.
Thank you. Good morning, Chair, Committee, Chair, and the committee members of the board. Thank you so much for the opportunity to speak. My name is Sean Kim from California Pharmacists Association. First, we appreciate the board's leadership and collaboration in recent legislation, especially AB 1503, the sunset measure, the modernized pharmacy practice through a standard of care, and SB 41, advancing affordability of healthcare through PBM oversight, which we will discuss more tomorrow. CPHA is moving quickly to support implementation. Earlier this month, Executive Officer Ann Sodergren provide us with the annual law updates, including AB 1503. Yesterday, we hosted legislative town hall meeting with nearly 200 registrants. In March 2026, the APHA and CPHA annual meeting in Los Angeles will hold a special session on the standard of care to help licensees operationalize the new framework and close care gap and align with the national best practices. With recognitions of advanced pharmacist practitioner, we are actively updating curriculum and the credentialing pathways to align with the updated statute and anticipated regulations, including application and continuous quality improvements. We also applaud the creation of the Pharmacy Tech Advisory Committee. CPHA recently hosted a webinar evolving technicians' role across the settings, highlighting the quality workflow and training needs can be informed to the committee's work. Finally, we continue to discussion with HCI, integrate the community health workers into pharmacy teams to support rural health transformation efforts recognized by in HR 1, advancing access, ensuring the care coordination, deriving outcomes where they are needed the most. CPHA is committed to partner with the board and co-develop clear implementation resources, FAQs, and case examples so licenses can meet the standard of care while protecting the patients and consumers. On behalf of our members, thank you so much for the stewardship and the passage of the board sunset review bill. We look forward to continued collaboration.
Thank you, Dr. Kim. I look forward to hearing you throughout the meeting. I'm sure will be many, many comments from you today. So look forward to our discussion. I don't see anyone in that room, so I'm gonna assume that we are good to go. And so we're ready for WebEx.
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment for items not on the agenda, please click the raise hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. And it looks like we do have a request from Jackie Stover. Jackie, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, my name is Jackie Stover, and I am a specialty pharmacist. I am pleased and excited about the recent passage of AB 1503. However, I am getting feedback from my employer that they're waiting on the Board of Pharmacy for clarification as far as remote processing is concerned. So my question is, does the Board of Pharmacy intend to provide clarifying guidance or policy on remote processing within AB 1503? Thank you for your time and consideration.
Thank you, Dr. Stover. Just a friendly reminder that we do have, if you look at our agendized item in the meeting materials, I think you'll be happy to see what we have coming today. So please stay tuned for today's meeting. We're ready for next public comment.
All right, this is the moderator. We next have Chasney Johnson. And Chasney, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hello, good morning, everyone. My name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I just want to make sure everyone attending, viewing, and participating in this California State Board meeting know how important this is to pharmacy personnel like myself. Some people are requesting days off to attend these meetings who are getting paid minimum wage and working less than 24 hours a week. With that being said, I would like to see the meeting start on time, video and audio being checked, and technical difficulties being solved before the meeting. WebEx and Zoom meetings do have a free video check to make sure basic computer skills and technical difficulties are understood. It is a privilege for being able to conduct and participate in a state meeting. It is a lot of responsibility, and we don't want to lower down the standards. I wish everyone a great day, and thank you for letting me participate today.
Thank you for the comments.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. Members, do we have any comments? Anything you would like to add for our future committee meeting? I don't see anyone raising their hand or coming to unmute their button. So we are moving to next agenda item 3, discussion and possible action to approve minutes of the June 12th, 2025 committee meeting. As we begin our discussion, I will ask if members have any questions or comments on the draft minutes from the June 12th, 2025 meeting, found in attachment 1 of the meeting materials. I would also entertain a motion if you believe such action is appropriate. Members, do we have a motion? Any comments? Don't be shy.
I'll move to approve the minutes.
Thank you, Renee. Appreciate it. Do we have second?
I'll second it.
Thank you, Satinder. With a motion and second, we're ready for public comment. Sacramento? Seeing none. Ready for public comment in WebEx. Sarah?
This is the moderator. For members of the public on WebEx, if you would like to make a comment on this item, please click the raise hand icon, or if you're an audio-only participant, you can press *3 on your device. I'll give them a moment to access those features. All right, and it appears there are no requests for public comment at this time.
Thank you. With that, we're ready for vote. Members, Trevor, how do you vote?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Claudia.
Yes.
Thank you, Satinder.
Yes.
Thank you, and I vote yes. Motion passes. Okay, next agenda item 4 is discussion of pharmacy practice experience requirements pursuant to Business and Professions Code Section 4209, including presentations and possible action to make a recommendation to the board. As the meeting materials reflect, pharmacy law establishes a requirement for an intern pharmacist to complete 1,500 hours of pharmacy practice experience before applying to take the pharmacist licensure examination. The statute further provides that an applicant that has graduated after January 1st of 2016 from an accredited College of Pharmacy is deemed to have satisfied the pharmacy practice experience requirement. The meeting materials also include information on the updated ACPE standard that all accredited pharmacy school programs must satisfy. This includes completion of introductory and advanced pharmacy practice experience. I think they're known as IPI and API to all the pharmacy folks out there. The standards establish rotation requirements and require completion of a total of 1,740 hours of experience. Because I believe it may be related to our discussion, I want to highlight that the accreditation standards do not seem to require all experiences to be related to direct patient care. Members of the board have received comments suggesting that the board should reestablish a requirement for an intern to complete internship hour affidavits or possibly outside of the practice experience gained as part of the pharmacy education. So just to provide additional education on this important issue today, we have 3 presentations. Like to first, it's alphabetical order for anyone wondering. We're going to, by last name, we're going to start with Dr. Sarah McBain. She is an associate dean with the University of California, Irvine. Dr. McBain, thank you so much for your time. I thought I'm hearing something. Sorry, is anyone talk? Are we ready? Was that you, Dr. McBain?
I didn't speak until just now.
Oh, there you are. Okay. All right, the floor is yours, and we're going to get the slide up, and we're ready to go.
Right.
Dr. McBain, sorry. Perfect. Thank you.
Yes. I'm not as versed in WebEx as I am some other platforms, so it took me just a second. So I have been invited to speak on behalf of the California Pharmacy Council, and I thought I would take this opportunity to outline for the board and the audience members here today the experiential accreditation requirements that all schools and colleges of pharmacy must adhere to. So, as many individuals are aware, the body that accredits schools and colleges of pharmacy is the Accreditation Council for Pharmacy Education, most commonly referred to as ACPE. And the standards were recently updated in this past summer. So the standards were approved by the Board of Directors of ACPE in June of last summer, released shortly thereafter for review, and became effective for all institutions this past July 1st. There are a few key differences from this iteration of the standards as compared to the previous iterations of the standards, which were commonly referred to as Standards 2016. So for this iteration of the standards, there is one document. Previously, there were multiple documents. There were the standards as well as the guidance document, primarily intended to help clarify some of the concepts. So the standards for 2025 were streamlined and made a bit more concise and hopefully a bit more digestible for schools and colleges of pharmacy or for any individual who wishes to review these documents. As a quick aside, these are publicly available. Anyone can access these on ACPE's website. In general, the philosophy and emphasis of Standards 2025 are that graduates should be both practice ready and team ready. And another key thing that showed up in Standards 2025 is the concept of diagnosing and prescribing as part of therapeutic treatment planning. Standards 2025 focus on a few different things, including the development of students' professional knowledge, skills, abilities, behaviors, and attitudes, including scientific foundation, knowledge application, and practice competencies. They also focus on the manner in which programs assess students' acquisition of knowledge and application of knowledge to practice. Highlight the key concept there is assessment, the mastery of skills, as well as the achievement of competencies, and the importance of both curricular as well as co-curricular experiences in advancing the professional development of students. Further key differences in these standards include the importance of assessment. So pharmacy programs are expected to collect and use outcome data from what their students and their graduates are achieving as a means of determining and continually improving the quality of pharmacy education. The standards are organized a little bit differently from what we saw previously. However, they include the same critical areas. And as I mentioned a few moments ago, they've been restructured and clarified and simplified. There is a comment on innovation. So programs may choose how to meet the standards. However, they still have to provide evidence of meeting the standards. And lastly, the standards have adopted the style from Chicago Manual Style 15th edition. This slide outlines the different standards that we have in Standards 2025. So for the previous iteration, Standards 2016, there were 25 standards. These have been condensed into 7 standards, as you see listed on the slide, ranging from organization and governance, curriculum, experiential learning, students and student services, faculty and staff, resources, and then finally assessment. Now I'm going to spend some time going through what's in Standard 3 for experiential learning, since that seems to be the most relevant topic for today. So 3 standards, and they are subdivided into 3.1, so forth and so on. So 3.1 focuses on the introductory pharmacy practice experiences, commonly referred to as IPPEs or IPPEs, depending on who you're speaking to or where you are. And these focus on common contemporary pharmacy practice models. Students must complete no less than 300 hours, 75 in communities, 75 hours in the hospital and health system, and the remaining 150 hours can be completed in various settings, but must include patient care. Simulation cannot be used towards this requirement, and this is a little bit of a difference here because previously schools and programs were allowed to count simulation hours towards the practice requirement, but that has been removed. Students can place out of some required hours. However, the schools must document achievement of the outcomes that would be expected from that practice settings. And if they place out of hours, then they must replace with other patient care IPPE hours. So graduates would still be completing at least 300 hours for their IPPEs. 3.2 focuses on advanced pharmacy practice experiences, or APPEs, APPEs. The APPEs emphasize continuity of care and incorporate acute, chronic, and wellness-promoting patient care services with the intention of exposing students to diverse patient populations. The duration of APPEs is no less than 1,440 hours or 36 weeks, and each APPE must be at least 160 hours. The majority of those must focus on patient care. Electives may be non-patient care. However, the max of non-patient care hours is 320 hours. So as you see on the right-hand part of the slide, the total hours of APPEs, or the total hours of experiential education completed would be 1,740 hours. Required APPEs include community practice, ambulatory care, hospital or health system practice, and inpatient adult care. These are the same as what we saw in Standards 2016. Also, before I leave this slide, I know that there is some attention on the cap of 320 hours for non-patient care, and I do find that that's relevant for us here in California, because if you refer to the for the licensure application for someone to become a pharmacist here in California, there is still an hours affidavit as part of that document, and it does note that 600 hours may be completed in other settings that are substantially related to the practice of pharmacy. Electives are intended as areas for students to further highlight their areas of interest and professional growth and development. There are quite a few documents that are required by ACPE from schools and colleges of pharmacy. So we have to provide an overview of our IPPE and APPE curricula. This includes duration, types of required and elective rotations, and so forth. Student and preceptor manuals for IPPEs and APPEs, along with the evaluation tools that both students and preceptors will use. Students would be evaluating the experience and the site, and then of course preceptors will be evaluating the student's performance on those rotations. Preceptor recruitment and training manuals or programs must be shared with ACPE. Also, student APPE evaluation data that documents exposure to diverse patient populations, as well as interprofessional team-based care, along with policies and procedures that are related to preceptor recruitment, orientation, development, performance review, promotion, and retention. Further documents required by ACPE, and I share this extensive list with you so you're aware of what's required, and also to highlight the level of rigor that is applied to pharmacy programs by our accreditors to ensure that these are in fact quality experiences that are contributing to students' growth into future practitioners. So schools have to provide a list of active preceptors and practice sites classified by the type of practices. specifying if it's IPPEs, APPEs, or both, along with the number of preceptors included, policies and procedures that are related to preceptor recruitment, orientation, development, performance review, etc. A list of all active preceptors. This is a duplicate bullet point, my apologies for that, but we'll just continue with this one. Number of students, how they're interacting with other professional students and healthcare practitioners, the number of preceptors serving the facility along with their license status, and the look back period is 3 years. ACPE also requires capacity charts. So these are IPPE and APPE capacity charts, which are essentially Excel documents where schools plot out the number of preceptors as well as the number of sites, essentially the rotation offerings that they have that show that there is sufficient capacity and ideally excess capacity to appropriately place students in required and elective rotations. Additionally, those are the required documents. Additionally, programs must describe how student performance is assessed and documented, including the nature and extent of patient and healthcare professional interactions, as well as the attainment of desired outcomes, how the school or college ensures that the majority of students' IPPE hours are provided in and balanced between community and institutional health systems, recognizing that those are still the primary practice sites where individuals go on to practice, how practice experiences assure that students have interactions with diverse patient populations in a variety of settings, how the program ensures that students' APPE hours fulfill the required for practice settings, how the college or school provides students with in-depth experiences in delivering patient care as part of a team, and how the school provides students with elective APPEs, including opportunities that involve patient care, allowing the students the opportunities to explore a variety of practice settings. This continues. Schools must also describe how they distinguish between introductory and advanced practice experiences and the growth and continuum on that spectrum, how the school or college applies policies and procedures for their preceptors, how schools foster the professional development of preceptors commensurate with their educational requirements or responsibilities to the program, how the college or school assures, measures, and maintains the quality of sites and preceptors used for practice experiences, how the program determines the need to discontinue using a site or preceptor that does not meet predetermined quality criteria. And this continues on. The number and percentage of all IPPEs and APPEs precepted by non-pharmacists categorized by type of experience. And again, recognizing that these standards are applicable to programs across the country. So this is, this is valid in some states outside of California. The college or school's student to preceptor ratio and how the ratio allows for individualized mentoring and targeted professional development of the learners. The process for soliciting active involvement of preceptors, including those practicing at a distance, in the continuous quality improvement of the education program, particularly the experiential component. The strategies used for the ongoing qualitative and quantitative development of sites, preceptors, and formalization of affiliation agreements. And then anything else, notable achievements that the program thinks that they're doing particularly well and wants to highlight for ACPE. And programs also provide an interpretation of the data from applicable AACP standardized survey questions, including notable differences from national or peer group norms. So schools and colleges of pharmacy are expected to look at how we're doing and then compare ourselves to peer institutions. The other component of Standards 2025 that is relevant to our discussion today are entrustable professional activities. This is commonly abbreviated as EPAs, and EPAs describe the work of pharmacists as workplace tasks and responsibilities that all students are entrusted to do in the experiential setting with direct or distant supervision. And the EPAs are listed as follows. Collect information necessary to identify a patient's medication-related problems and health-related needs. Assess collected information to determine a patient's medication-related problems and health-related needs. Create a care plan in collaboration with the patient, others trusted by the patient, and other health professionals to optimize pharmacologic and non-pharmacologic treatment. Contribute patient-specific medication-related expertise as part of an interprofessional care team. answer medication-related questions using scientific literature, implement a care plan in collaboration with the patient, others trusted by the patient, and other health professionals, fulfill a medication order. So these are the entrustable professional activities continued on this slide. Educate the patient and others trusted by the patient regarding the appropriate use of a medication, device to administer a medication or self-monitoring test, monitor and evaluate the safety and effectiveness of a care plan, report adverse drug events and/or medication errors in accordance with site-specific procedures, deliver medication or health-related education to health professions or the public, identify populations at risk for prevalent diseases and preventable adverse medication outcomes, and perform the technical, administrative, and supporting operations of a pharmacy practice site. So that concludes the slides that I have pre-prepared to share with everyone this morning.
Thank you, Dr. McBain. Do we have any questions for Dr. McBain from our members, committee members? See
Hi.
none. Oh, go ahead, Claudia.
Hi, good morning. Can you speak a little bit about how you're collecting information on the students' feedback as stakeholders throughout the process of their education?
So that is going to vary from program to program, but it's collected in a variety of different ways. So the evaluations that are submitted as part of the process, this is generally submitted, it is submitted on every rotation. So ACP expects that of us at the conclusion of that site. So the preceptor will conduct an evaluation of the student using some sort of software system, and the student will provide an evaluation of the preceptor, and commonly it's of the preceptor and the site. And then that is collated and summarized, and then it will be shared back with both the sites as well as looked at the program level.
Okay, and one just last quick question. I'm not a pharmacist, but how are the hours tracked? Is it mostly done through software systems and reporting through a centralized?
It is mostly done through software systems. And it's sort of pre-assigned, and students are, they are alerted ahead of time, like these are the hourly expectations. And many schools and colleges of pharmacy on their evaluation form will have a checkbox for the preceptor stating like the student completed X number of hours in this practice setting.
Got it. Okay. Well, thank you so much, Sarah. Appreciate you.
Thank you. Thank you, Claudia. Dr. McBain, hopefully you can stick around and part of, kind of answer if you have any questions at the end of our agendized item after two other presentations. We would appreciate it.
Thank you.
Thank you. Okay, so we just have to open up for, I know you already turned off your camera, but we have to, as a public agency, we have to just kind of go for public comment really quick. As a reminder, public comment is not intended to be a question and answer session, rather an opportunity for members of the public to comment on the information presented. Dr. McBain, should members of the public ask a question, you are welcome, but you don't have to. So just wanted to set that out. Do we have any public comment in Sacramento? I don't think Sean is gonna say anything. And we're ready for public comment in WebEx.
All right, this is the moderator for members of the public on WebEx. If you would like to make a comment on this item, please click that raised hand icon, or if you're an audio-only participant, you can press *3 on your device. I'll pause just a moment to allow people to access those features and submit their requests. All right, and it appears there are no requests for public comment at this time.
Thank you. Thank you again, Dr. McBain. We're ready to move on to our next presentation. I'd like to welcome Dr. James Scott. He goes by Jim, and who is the formal dean for Touro University. Dr. Scott, thank you so much for coming, and hopefully everything is ready to go. So I do not see him on the screen, but hopefully we can get him on.
I am here, and I have my camera on.
Perfect.
Yes,
There
and
you
I
are.
don't have slides today, so I'm just going to talk. I do have some prepared notes. The first thing that I want to do is I do want to add on some information from Dr. McBain. So there is 1,740 hours required with the new standards, actually with the prior set of standards as well. And with the new standards, they limit non-patient care rotations to 320 hours. However, in the state of California, all of the schools here have 240-hour rotations, 6-week rotations. And so even though that 320-hour rule is there, it's really not something that we can achieve in California, because we'd either exceed it or we'd be under it at 240. And so then if you take that 1,740 required number of hours and subtract out 240 for the non-patient care electives for those who chose to do it, we are still looking at 1,500 hours, which is the basis of the requirement for the licensure from the board here in California. So with these new standards, we do still have at least 1,500 hours of patient care rotations that are required for all licensure candidates. So I've been around California long enough. So I am the former dean from Touro University, California. And prior to that, I spent 11 years overseeing the experiential program at Western University of Health Sciences. And I started as a faculty back in 2000. So I've been around for a while. One of the things that we found is that the accelerated programs, the programs less than 4 years, their students have a harder time fitting in the internship hours because they go year round. They don't have a summer off. And exactly how they go year round will vary from one school to another, depending on how everything is set up. But currently, half of the schools in California are somewhat of an accelerated program. We have one program that's 3.5 years and 6 more that are 3-year programs. And so this puts a very difficult burden on the students going through school to be able to find the time where they can dedicate to the internship hours if they were required to be separate from the required rotation hours. And give me a second while I pull up my notes. So a lot of the stuff that I was going to talk about, Sarah already covered, which was the experiential requirement. So I think overall as well, the candidates, what I've seen across the board is the candidates have they struggle a little bit more going through the program. They all successfully complete it. They have benchmarks that they need to do and those types of things, but many of them are not able to work during pharmacy school because of the pressures within the academic institutions. And so based on my experience, my opinion is that having to go back to additional external hours from the academic program would be quite cumbersome for many of the students who are in school and will be in school. And then the last thing is going to be more from an administrative perspective of the College of Pharmacy, is that there is a certain amount of workload from the college associated with these external rotations and these verification forms. I know the schools that I've been involved with, and most of the other ones, have a close relationship with the Board of Pharmacy, and they typically will review all of the applications from the graduates before they actually get sent out. In fact, most of the time the school sends them out in one big batch. And so the people within the school are involved in reviewing these applications and making sure that their names are spelled correctly, that they didn't leave a number out on their social security number, and that the forms are completed correctly. They don't do that for them, but they will send it back to them if they have. And so these internship hour verification forms do put a workload burden on the schools, many of whom, because of lower enrollment, have budget constraints and as such personnel restraints. And I presume that there is also a significant amount of workload from the Board of Pharmacy of reviewing all of that as well from their staff and their folks. So that was kind of what I wanted to give as my proactive stuff. I'm happy to answer questions, or if there's a discussion that follows, I'm happy to be part of that.
Thank you, Dr. Scott. Members, do we have any questions for Dr. Scott?
Hi, Dr. Scott. This is Claudia. Hi, really quickly, what do you think? You say you were the dean of Touro University. What were the biggest challenges facing students, or some of the feedback you heard into how we can improve the system? Just so we can make it short for us, but so that we have it, you know.
The CPJE is the biggest concern of the students who are coming through. The fact that it has a lower pass rate than the NAPLEX, and it is then seen as the biggest barrier to licensure. I think most people coming out right now would much rather see an MPJE or, like some states, no law exam. And I know that this particular topic, which is tangential to our original topic, has been sent through the tumbler a few times throughout the state. But the CPJE is their biggest concern.
All right, thank you for that. Appreciate it.
Sure.
Thank you, Claudia. Thank you. Okay, we're ready to go to public comment for you, Dr. Scott. As a reminder, public comment is not intended to be a question and answer session, rather an opportunity for members of the public to comment on the information presented. But if you are asked a question, you're welcome to answer. With that, public comment in Sacramento. We're ready for public comment in WebEx.
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raised hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. I'll pause a moment to allow people to access those features and submit their requests. And it looks like we do have a request from Richard Dang. Richard, you'll be given 3 minutes to speak in a 10-second warning. Please click the unmute me button when the prompt appears on your device. All right, and Richard, looks like you are still muted. I'm going to request to unmute you again. Please click the unmute me button when the prompt appears on your device.
Hi, can you hear me now?
Yes, we can hear you.
Perfect. Hi, this is Richard Dang. I'm faculty at University of Southern California, speaking for myself. I'm curious if any of the panelists or maybe even board members might know how many other states currently have an intern hours requirement that is external to the experiential rotations. I'm not sure. I know that information. I'm just curious if we have that as a part of this discussion. Thank you.
Thank you, Dr. Dang. I do not know the answer to that. I don't know if anybody knows. We will get to it if we do find out the answer, but we'll move on. Any other comment?
And this is the moderator. Oh, I apologize. Actually, we do have another request for public comment from Kathleen Besnick. And Kathleen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Can you hear me okay?
Yes, we can hear you now.
So my name is Kathleen Hill-Besink. I am with Chapman University and have been an experiential director for decades in California. I wanted to respond with there actually is a database source for finding out what states' intern hour requirements are. I don't have the exact number for you, but I can tell you that the vast majority of states do not have an external requirement beyond the ACPE experiences. The National Survey of Pharmacy Law 2025 would be my source, and I can send you that document if you would like it. Also, I wanted to mention that ACPE does require during their accreditation that students have, or that schools have some way of showing that students actually earned the hours that are required during their experiences. Many of the schools, including the ones that I have worked at, do have a way of logging student hours, and preceptors are additionally asked to verify that the student completed the minimum number of hours. That's often part of the evaluation form itself. So there is a documentation process that is involved in that. And the third comment I have has to do with the non-patient care hours. The limitation of 320 non-patient care hours doesn't mean every student does that. It just means that students who wish to do an elective in an area, for example, like maybe managed care or pharmacy administration, or in some cases, it might be pharmaceutical industry, have an opportunity to do one of their APPEs in that area. In the old days, and I've been around for those old days, those hours would have been considered part of the 600 hours that schools are able to sign off for as being related to the practice of pharmacy. So in essence, 320 hours is less than the 600. that are currently listed as being available. Thank you.
Thank you for the comments, Dr. Basink.
All right, and this is the moderator. It appears there are no further requests for public comment at this time.
Thank you, Sarah. We're ready to move on to our next presentation. I'd like to welcome Dr. Scott Takahashi. Dr. Takahashi, thank you for your time, and the floor is yours.
Pulling up my window. Hold on a sec. Can you see the screen?
Yes, we can.
Great. I'm unfamiliar with this process of basically testifying to the licensing committee, so I appreciate the opportunity to speak to you. What I'd like to do is just kind of briefly talk. There's kind of a glossary of things I want to cover, as well as a brief overview of my, hopefully be a very, very brief presentation. To introduce myself, I'm a registered pharmacist. I've done a lot of things within the pharmacy realm, practiced in many practice areas, and done internship, and I graduated the USC program, as well as an inpatient clinical residency at LA County USC. During that experience, I got to work with second-year students in IV rotation, third-year students learning about clinical case presentations, and fourth-year students doing their API rotation. So the residency kind of built on that, the foundation of teaching. I am speaking as myself as a registered pharmacist. However, I have been a past president of the California Society of Health System Pharmacists. And at Kaiser Permanente, I practice in both an inpatient initially and an ambulatory care practice ever since. So in my capacity as a pharmacist at Kaiser Permanente, API instructor from 1991 through now. I did IPI instruction for a few years, and I've been the API coordinator and ambulatory care pharmacy practice experience coordinator for Kaiser Permanente at the Los Angeles Medical Center. As in my experience as a clinical instructor, I have over 200 patients in ambulatory care. I've got experience with as an instructor for the schools of pharmacy at USC, UCSF, University Pacific, and Western. I'm the site coordinator, which means I'm the big bad wolf in the room when there's a problem with a student or an instructor. I will work with the student and the school and the instructor to mediate and solve the problem. As an experiential preceptor, I'm also an instructor for our Department of Pediatrics, Family Medicine, and Care Management. So when the physicians are on site learning about how we take care of patients, primarily in the asthma realm, I'm the primary preceptor for that for those students too, those residents as well. I've been teaching for a long time. I've gotten some teaching awards, and that's all this is about. But I just want to let you know that I'm a frontline pharmacist who does real patient care work as well as an instructor. So I've got a fair amount of experience and exposure to our students from the schools of pharmacy over the many years. So 4209, like was mentioned earlier, allows for the 2016 revision allows for students to get all their hours to sit for the board exam from the schools of pharmacy. And that's the reason I asked the question, because I've seen a change in our graduates over time. And being very practical, I think a lot of it comes from the lack of experience during their internship years while they're in school. In the old days, and this is where Kathy Basink and I, Dr. Basink and I grew up, because she was my API coordinator. 1,500 hours are required to sit for the board exams. The schools are able to provide 600 of those 1,500 as a sign off for API hours or clerkship at that time. And the pharmacy candidates were required to earn 900 hours on their own. The problem is that in the early 2000s, late 1990s, early 2000s, we had a significant pharmacist shortage, and we had issues with trying to get out-of-state pharmacists to apply for California licensure, because at that time we didn't use the NAPLEX exam, so we weren't reciprocal with our licensure. So a pharmacist was licensed in California could not carry their license to another state. The other thing is that as the Touro College of Pharmacy and California North Coast College of Pharmacy opened up, the Thomas J. Long School at University Pacific was not able to get internship hours for their students because essentially those hours got soaked up by API and IPI experiences for the new schools. And I think that's been kind of a wave over the entire state in terms of availability of programs. So something to keep in mind. In the current form of the regulation 40209 was accepted to allow internship hours to be applied and sourced to all the different schools of pharmacy. What I'm asking for is consideration to consider returning to the pre-2016 verbiage. So you got to get the hours to sit for the exam. You have to be a registered pharmacy intern with the Board of Pharmacy before you accumulate those hours. As a student at USC, the school really facilitated getting that done. So in the first week of school, we got all our fingerprints, pictures, and applications sent off to the Board of Pharmacy. The hours that you must get outside of school must be under the registered pharmacist. You need to provide an affidavit. The pharmacist must sign basically their license away to attest that you have done those hours, which is a responsibility of our practicing pharmacists. And again, the schools were able to provide up to 600 hours through API and IPI experiences. So hopefully, this is where I'm shooting for. This is more the verbiage as I was able to find it from the licensing committee minutes of December 11, 2013. So I went through a bunch of the licensing committee meeting minutes to dig up information that really is no longer available because everything's electronic. So this is basically what I'm asking for consideration. And I think the interesting thing with this is during the 2013 minutes, at the very bottom, California North State University expressed concern about the board's licensing staff about the appropriateness of forms being completed by colleges in California, but there's no written statement from the school. The other thing I thought about as I read this section was, if the dean is not a pharmacist, does that mean that a pharmacist on the school staff must sign for those hours on behalf of the school? That's just an aside I came up with as I was reading through these documents. Time to give you some of my personal recollections. With all the students I've worked with and all the pharmacy interns I've worked with, our best students had done the best because they had worked a lot. They worked every weekend. They soaked up hours during break time from classwork, or just whether it was vacation, a holiday, someone called out sick, but they worked. Personally, if you do this, you can integrate practice into classwork and back and forth. So you actually this is truly the apprenticeship component of the internship experience. I think that's where it's really valuable because this is over years as opposed to 6 weeks. Personally, I worked 20 hours a week until the middle of second year, and then my grades kind of took a hit, so I dropped down to 16 hours per week. Part of it is because I need to buckle down and study more. The other component is involved a lot of professional organizations and elected offices within the School of Pharmacy, and actually was student body president for the school during my fourth year of training. Again, the apprenticeship aspects of on-the-job learning of the pharmacist's duties and roles while interning is going to change throughout the time that the intern is actually working. So the other thing I want to throw in there is that the Board of Pharmacy exam was done differently back then. It was only twice a year at 2 12-hour sessions per year. So that's kind of a different experience that I had. I think from the more practical work from the field is that the Doctor of Pharmacy program was expected to graduate in good pharmacists who can practice in most practice settings. The PGY1s were really to get clinical practice pharmacists off the deck. And then the PGY2s or fellowships were able to create subspecialists. Now, looking more practically at what's going on nowadays is internship experience can be one thing that helps someone stand out from the field in terms of their ability to practice. And the other thing that's more confusing, and I think the academic staff on the call can speak well to this, is how artificial intelligence with grammar and editing make statements of interest, of intent, less meaningful because it's more generic. So I'm not sure how we're going to deal with that, but that's something that as instructors we need to sort out. More practically, new grads are coming into practice not knowing how to work, not knowing how to do basic things like getting in and getting out of the office or the pharmacy, taking time out for lunch appropriately, working with their colleagues and staff and management are important skills that you build up through your apprenticeship or internship experience. I think the thing that is important with our apprenticeship or internship experience is that the accountability level tends to be a little different for internships versus APPE and IPPE experiences. For me as an instructor, I'm focusing on the students' ability to process complex clinical information, and they're really not in the mode of handling work apart from just patient calls. So I take care of the technical aspects of our interactions. As well as in the oncology service, the students are not really in the mode of handling product and preparation. They're really in the mode of learning about the clinical aspects of pediatric oncologic care. That's my morning job. My afternoon job is taking care of patients with asthma. As an intern, you should be teaching how pharmacy practice goes to the next set of interns, your successors. As an intern during your apprenticeship, you should be developing your own personal work ethic, your own personal persona on how you present yourself as a pharmacist, and you're rapidly building your reputation for how you work, whether it's good or bad. Hopefully it's good. You develop the management, the skills to manage people around you and work with you, and how to supervise staff. So, honestly, you learn from technicians during the first part of your internship, and then you start learning from your pharmacists. And by the time you get to the end of your internship, you should be learning from your pharmacists to be one of them, to be one of their colleagues. Another aspect of apprenticeship is time management. If you've got 8 hours to do something and you've got different priorities, you're going to need to figure out how to make all that work. And honestly, although it's exhausting, you have to balance your work commitments on the weekends or an evening during the week with your classwork, and that's very important to be able to clearly graduate. Again, the IPPE-APPE experiences tend to be more instruction oriented than the mode of being an employee. And I think the other thing that stands out in terms of our apprenticeship versus APPE experience is that these modes of thinking and these practice methods are developed over years instead of weeks. So I think if we look at just doing the math, if you work 16 hours a week, week and Saturdays and Sundays for 2 to 3 years, you can get as much as 2,500 hours of experience on the weekends. You'll be a little tired, but hopefully you'll be stronger for it. I think the other things that I mentioned before in terms of what interns do versus what students do, they'll deal with all the day-to-day stuff that happens in the pharmacy: medication shortages, controlled substance management, dealing with staffing and people around you, getting things done, and using their clinical skills as appropriate to your educational progression. So as I mentioned before, you'll start integrating your classwork into your weekend work and vice versa. So classwork becomes much more simple and straightforward because you're used to seeing these drug doses and strengths as it crosses your desk in the pharmacy. So when you see it in the classroom, you're just saying, all right, so that's why that's given that way. That's why that works that way. That's why you watch out for those things. And then you integrate all those experiences together. Now, as the new schools opened up, we back in the old days, in my day. It was only 3 schools of pharmacy, then Western University, and now we've got a lot. With the experience we have at University of Pacific, when programs opened up, there was a decrease in available internship hours. When I spoke with ACPE during an accreditation visit, they responded that they're only responsible for crediting programs. They don't approve a program to be opened. So that means that the business aspect of opening a school of pharmacy may have missed the mark in terms of hitting the shortage and providing necessary staffing, and now it's a lot of schools may be struggling just to fill classes. COVID-19 has had a marked impact on our internship programs because there's more interest in non-traditional practice settings. People are afraid of getting infected, so they look more into industry and other areas that don't involve direct patient care, and that may be a reason why people are going that way. And honestly, I'm old, so there's generational shifts as well. People have more things like gap time, more unwinding time, changes in work ethic. And it's not to say that all pharmacists who are getting out of into practice now are treating their job as a profession, but there are a fair number of pharmacists who treat their job as a job. So it's kind of losing touch with that professional aspect of how we practice. NAPLEX came into effect in 2004. I was on the CSHP board of directors when this was announced. The exam pass rates have been somewhat dwindling over time. I grabbed the CPHE results from this November 2024 to 25 board exams. Unfortunately, with the pass rates diminishing, we've had to deal with a lot of interesting things, including the dismissal of PGY-1 residents, because they have to be licensed in that state that they're in their residency with for at least 8 out of 12 months. So if they don't pass the boards by the second go-round, they may be dismissed from the program. And I think most recently from my work with the CSHP board of directors is that there was talk of consideration of multi-state jurisprudence exam, which was basically just put down to continue with CPJE. The impact of restoring internship hours may be significant. Students may have difficulty fielding those internship hours and may not get to graduation by the time they're ready to sit for the boards because they've completed their training. They may not have the hours enough to sit for that. I do apologize for that, but that's not a consideration from my perspective as a practicing pharmacist, that I want to have good colleagues that I work with, and I want those colleagues to be well seasoned. And I think they can be much more prepared to enter the workforce if they have the internship hours behind them. So that is a gist of what I had to talk about.
Thank you, Dr. Takahashi. That was very insightful. We really appreciate your time. Thanks for coming and sharing. I'm going to open up for members. Do we have any questions or comments for Dr. Takahashi?
Hi, Doctor. Trevor Chandler. Just want to dive a little deeper into kind of your assessment and about, this being viewed more as a job versus a profession. And just curious as to, what can the board do as we're looking through all the venues that we're looking at? How can we assist in, from our vantage point, in helping really make this a profession versus a job, and how can we work to incentivize and empower those folks?
There's a couple things that probably go into that equation. One of them is how the schools, and this is not under our control, how the schools present what you're going to be doing when you graduate. If you look at the more practical aspects, majority of pharmacists will end up in community practice. That may be changing now with the 24-hour pharmacies and multiple pharmacy systems closing, but most students that graduate and go into community practice, with a minority going to hospital practice, partly because of the intensity and partly because of the hours. When I was an inpatient pharmacist, covering vacations means I worked almost all the weekends and all the evenings because everyone took vacation when they weren't on day shift. the other thing is that if people want ambulatory care practice like what I do, or inpatient practice, and you must complete a PGY1 residency just to be a viable candidate to sit for an interview. So that makes it more difficult. And I'm hoping that the pharmacists who have completed residency, which is a minority of our graduates, will treat their profession as a profession and not just a job, just punch a ticket and go home. The perception of how people are treated as employees in an outpatient or inpatient, or even ambulatory care setting varies from institution to institution. In my institution, I'm an hourly employee, so I must punch the clock in and out for lunch and in and out at the end of the day. And most of the time, I am not just sticking to those hours. I'm putting a lot of extra time and investing more of myself into that. But depending on how the labor board has positioned pharmacists as labor, that makes it harder to bolster the perception as a profession. And I understand where that came from, because the issues I think I'd heard during in my tenure as CSHP's board is that pharmacists in the outpatient setting weren't being given lunch breaks, time to use the restroom, and they had to shut down the pharmacy as soon as they left it to use, to take care of themselves or take a break. And that became an issue with the business of running a pharmacy inside of a retail setting. So I understand where the labor law kicks in and why that's important. But at the same time, it is up to the individual pharmacist to make their profession, not just a job.
Thank you. Thanks, Trevor. I'm just gonna add to that. I think just honestly, my time on the board, and that's a great question, Trevor. And I mean, I always joke, but I'm serious that I love my job and I love what I do, and it really helps, right? If you love what you do. But really, to me, I think what we've been doing as a board for the last many years, 4 or 5 years, of really advancing what pharmacists can do to take care of patients, improve public health, has been remarkable. And what we're about to discuss in agenda item 5, which I'm sure everybody is very anxiously anticipating to talk about, because there's a lot to talk about, is really now finally, I think, culminating to the final point of what we are about to implement starting next year, which is allowing pharmacists to feel empowered to do what they can do, and notwithstanding the labor questions, I think pharmacists starting next year will really be able to transition into a different practice model that we haven't thought about in mainstream world. And that's my hope, is finally pharmacists being able to, doing things that are really outside of the box, and, being able to do things that are really creative, innovative, but also what's best for patient care, because it's going to improve access for patients to receive these care. So I'm hoping that with that, what we've been doing already, I think, is super significant. So I'm just proud of our accomplishments so far at what we were able to do at the board. But of course, the generational stuff and the workforce and the current work environment and the residency and the changes in work ethic, and all of those are just so much beyond what we do. But I think we are doing so much at what we can do in terms of that job versus profession. And I'm hoping that, that we will really be able to push forward for the next year. There's a lot more discussion to come, so I'll hold my further comments. Renee, I'll go to you, and then we'll go from there.
Okay, thank you. Yeah, thank you for all, excuse me, all the presentations, and Dr. Takahashi, because I'm also in the old school. I've been through all the changes, worked all the hours during pharmacy school. So, and I appreciate hearing, let me just ask Song. So was this kind of before we go to public comments for us to discuss? Correct. Okay, I just want to make sure that I'm missing something. So I really appreciate, it's really impressive to see, all the intention that goes into developing the programs for students. and the growth and development of all of that, certainly from when I was in school. I mean, it was there, but it's great to see that it keeps enhancing, right? I do want to speak first to this last question, kind of from Trevor, but I feel that honestly, no matter what you do, it's your mental choice whether you have a profession or a job, because what you do is important when it's patient care. So whether you are, I've always been in a hospital setting. So whether you're internally, focused on operations, I mean, it is direct patient care, right? I mean, you are preparing things that are going to go direct to the patient, but you may not be the pharmacist who's interfacing, but that is part of your team, and you are part of that team. And I have seen people who sort of will, not be able to keep that. Maybe they are very direct patient care focused, and yet, kind of start feeling like it's just a job. And then there'll be something and they'll regenerate themselves, right? Their resilience. But I do think that to some extent, all of pharmacy, I mean, it really is a profession, and I think it's really your outlook on what's happening. There's no way around that in pharmacy, like some aspect of pharmacy is going to be providing medications, right? I mean, you will be doing it either directly or indirectly, right? So I just wanted to kind of make that comment. And I do appreciate the presentation here from Dr. Takahashi, because I would say, we have residents, we have students, and I had interns reporting to me for many years until that pretty much stopped. We do have, some, but the learning that they have, and I just really appreciated some of your comments about the integration, right? The integration of what they're learning in the classroom and seeing it in action. So, watching these aha moments for these students when they are filling, and this is a pediatric institution, so that I've been in for many years, decades. And so seeing the light come on when they see sets of medications go out and they go, oh, I understand. Like, I know what's going on with this patient, right? So there's some of that aspect that links the clinical work with the actual patient care. Then there's also just learning how to work. So I really appreciated that of yours, because many of the students, these are brilliant kids. I mean, my joke was always trying to go through, we would get lots of applications for interns, and I would joke that like, oh, they like for their in their summers, they don't work. They don't have necessarily paid jobs, but they're in a lab curing cancer, world hunger, right? I mean, they're really amazing stuff that they're doing, but they don't know how to just like get a schedule, remember to come in on time, and cover somebody for a break, and realize that they're an integral part of the processing going on. And we did have kind of a program where when they were first starting, they do mostly operational shifts, so like with technicians, so technician work. But how better to know what you're overseeing as a pharmacist, than to learn some of the hands-on work and understand some of the limitations of and questions that you might have a pharmacist, and witness a pharmacist responding and overseeing you. And so that's so that goes hand in hand, knowing that you're going to be a pharmacist, right? And then we would have them do some more like chart, some other review, med review, and that as they continued to stay. And I would say that one of the key things about this too was, this was true in my case, and I think a lot of people, is like, it was really great to earn some money during school. So yeah, I worked every other weekend. And so, I mean, it's not a lot, but it was some. And some students really need to earn some money that's just helpful for them, right? Instead of putting it all on their loan. So we'll still have a majority, well, obviously some get paid for, but that they have the opportunity to earn some money. But I think being part of that is so important. And then I also want to say that we have seen that in interviewing and in residence, because we have PGY1 and PGY2 programs, PGY1 residents who have had intern hours or have worked in some way like that learn faster because they've already interacted with the electronic health system and they understand some of the basic processes. And then also another aspect that I think they learn as interns is in the environment of the highly regulated pharmacy, controlled substance, security, drug storage, medication inspection. Anyway, there's just a lot that they really learn, and we do have students that come through now, and they're great, but they only get to kind of observe. There's not much they can really do because they can learn some basic training, but otherwise, they're in and then they're out. They're there for like a month or so. I mean, I don't do anything with that program, but yeah. So but I see the limitations on the availability because as the pharmacy schools develop, they are not necessarily around areas where they can have a lot of interns. So, in our location, the schools are far. I mean, it takes easily an hour for them to get to our location. So, it's like almost not realistic. But we've had people who did do all that, right? They really committed to it and they did it. So, but it is not, as far as like this next step of talking about if there should be a change in what it should look like, it's hard to have something really hard and fast because I think there's just not that many intern positions. Certainly not now. I think they could ramp up some, but I don't think it's going to be as easily available. So
Thank you, Renee.
Anyway, thank
you. Other members, we're going to talk about this. Go ahead, Satinder. We're going to have a more holistic discussion after, so just keep that in mind. Go ahead, Satinder, then I'll go to you, Dr. Takahashi.
I have a quick question. Thank you. I think a lot of it is covered by both you, Dr. Song and Renee did. But my question is, yes, I'm from the old school too, and I did go to 3-year program, which was accelerated at the time. So I understand the difficulty of not having summers available and be able to work outside of your assigned, school epi or epi rotations. I completed most of the required hours, some in school, but mostly afterward, which does make it delayed in terms of getting your license, in terms of getting hours certified. So I understand that's a real concern. And I do also understand that the time that I spent working as an intern versus what was school required did provide me with additional opportunity in honing my skills and consumers benefits if you have a very well-trained pharmacist. So the fact that you're proposing switching back to the 900-600 combination, would you be willing to consider that we didn't have IPPs in those days, as it was implemented later on? Would there be another combination that would be kind of maybe not revert back to the old way, but some sort of like a less of a requirement outside, considering student commitment with the IPPs and EPPs and accelerated programs? So that's a question I have for Dr. Takahashi, if you can comment on that.
Well, as far as the hours between IPPs and APPs, those, in the old days, the IPPI was an clerkship program that USC had where they set the students out for 4 weeks at a time in community and hospital practice once per semester. And that got adopted into ACPE as IPPEs. The other IPI component from the program I graduated from was making IV medication, intravenous medication for LA County hospitals. So during second year of pharmacy school, our students in the second year of program were committed to do manufacturing for the county hospital. So we spent 5 wonderful hours every morning for about 2.5 to 3 weeks making IVs for county. And when you go back to your classroom, you smell like sodium thiosulfate because they use a sulfate-based alcohol to clear to prepare the areas. So that was the thing. The API rotations, there was no limit on how many hours you put in. Some of our best rotations, the students are putting in 10 to 12 to 14 hours a day, learning actively during their API rotations on the more, clearly the more invigorating programs. The hours are tough to get, but if you put in 16 hours on the weekends in a 3-year program, you'll get 2,000 hours plus. So, that the changes are that, as workers, our current students are not as invested, it seems, that there's more likely to call out sick instead of soaking up hours from other people's sick calls. And it's harder for people to get into a hospital or an internship position because the employers are not going to create positions for people who are not going to show up. So that's a generational thing that we have to work through both as a profession and as well as the schools of pharmacy. Because the schools of pharmacy are first line to tell students to go get a job. That to be successful as a pharmacist, you should have an internship position that you're doing. So I think that's a vital component of what we should be investing time into. As far as what was mentioned earlier in terms of making your profession your persona, in my off time, I actually donate my hours to the LA County Department of Health and work as the co-chair for the Asthma Coalition for LA County. So coordinating multiple disciplines, school nurses, outdoor air quality, indoor air quality, advocacy, clinical practice, into a package that we can present and help provide better care throughout LA County and model that for other counties around us, and really help patients who may be underserved because of their situation or location or their insurance. So do what you do, learn what you learn, and pass it along. Don't keep it to yourself. We shouldn't be in that mode of not being a professional just because we're not on the clock.
Thank you, Dr. Takahashi. We have a little more time. So I think we're going to go, hopefully, we have a couple public comments. So I think we're ready for public comment, and then we're going to bring it back to our discussion. So we're ready for public comment in Sacramento? Seeing none, we're ready for public comment with WebEx. I know there's Dr. Souza raised his hand, very patiently waiting. So I see him. I see Dr. Scott also has raised his hand, and Dr. Dang. Oh, there's the public comments coming. So we are ready to go to public comment. Then we'll have some more discussion really quick among our members and see where we go first from here. Sarah?
Okay. This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio-only participant, you can press *3 on your device. And first I have Kyle Sousa. You'll be given 3 minutes to speak in a 10-second warning. Please click the unmute me button when the prompt appears on your device. All right, it looks like you're still muted, Kyle. What? Wait. This is the moderator, Kyle. I see that you're unmuted, but I'm not hearing any audio.
I actually don't see his, I don't see his, I don't hear him. We can go back to Dr. Oh, there you are. There you are. We can hear you. Go ahead.
Appreciate that. Sorry about it. Good morning, board members, and appreciate the opportunity to speak. My name is Kyle Souza, and I serve as the Dean for Loma Linda University School of Pharmacy. And I'm also a member of the California Pharmacy Council. I respectfully urge the board not to increase the pharmacy practice experience hours beyond those already required by ACPE accredited programs. And while I certainly appreciate the discussion, I would ask the board to consider if they have collected or have any data indicating whether past practice experience hour requirements improved patient safety versus those that we currently have. It's also worth mentioning that if there are any concerns about oversight or quality, practitioners and members of the Board of Pharmacy are in fact invited to observe ACPE on-site accreditation visits. This really does help ensure continued alignment, accountability, and transparency. And ACPE, during any of its rollout of its new accreditation standards, often invites opportunities for stakeholders for public comment to share feedback and raise concerns during that time. One last point I'd like to make regarding ACPE's authority, and I certainly do not speak on their behalf, but I am a site visitor. But their authority really comes from its recognition under federal law to accredit programs for eligibility for Title IV financial aid funding, not necessarily to control supply or access, whether I agree with that or not. And because ACP is not a government regulator, it cannot lawfully restrict the number of schools that open because it would risk antitrust violations and restrictive trade concerns. I appreciate your time and thank you for allowing me to comment.
Thanks for the comments, Dr. Souza.
All right, this is the moderator. Next, I have Richard Dang. Richard, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, thank you. Richard Dang, faculty at University of Southern California, speaking on behalf of myself. I am also a residency program director for many years, as well as a preceptor for IPPE and APPE rotations. And we also have an internship program at the pharmacy that we work out of. So I also have frontline experience in all of these as well as the academic side. I certainly appreciate all the comments, and I share many of the concerns that have been discussed about generational changes in student approach and work ethic and all of those comments that were brought on. But at the same time, I think I don't agree with changing the hours to go beyond what is currently required by ACPE. I have a few notes about the different comments that I made, so I'll just kind of read them out as I see them. The current requirements for the ACPE hours for IPPE and APPEs do not prevent any student from seeking an internship. So if there's a student who wants to make extra money, who wants to get extra hours, who wants to get extra experience, they can certainly do that. And those outstanding students do that. And we encourage that to happen as well. I'm a strong advocate for my students seeking work. I tell them to get internships. It was important to do that. The old requirements that were cited from 2013 and beyond were present when there were no standardization of experiential rotation requirements and hours from ACPE. That has drastically changed. And as Satinder mentioned, there were no standard minimum hours for IPPE rotations at that time. There are now minimum number of hours. When you compare the hours required by ACP from 10 years ago to now, there's a significant increase. Additionally, those ACP hours are minimum requirements. There are many schools that are going above and beyond what is minimally required by ACPE. So they're offering more experiential opportunities. And I know that our institution is looking to increase those hours as well, because we value the hands-on practical experience. Working is important. There was a comment about institutions struggling to seek sites for the IPPEs and APPEs, and that is true. But if we're having difficulty seeking sites for IPPEs and APPEs, won't we have a similar problem seeking required internships for our 2,000 students in California? So won't we have a similar issue here as well? 10 years ago, we didn't have as many students, as many schools, and it wasn't as difficult to get internship positions. But now we are seeing an increase in that. So I think that is going to continue to remain a problem regardless of which direction we go towards. And I think ultimately the Board of Pharmacy is looking at, protection of the public, consumer protection, and public safety. And I think the ultimate question is, are personal opinions about work ethic aside and student generational approaches, is the public currently being protected by our current standards? Are the
10
standards
seconds.
for hours and examinations sufficient? And I think we might find that they are currently sufficient. Thank you.
Dr. Dang?
All right, this is the moderator. Next, I have Stephen Gray. Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you very much. Can you hear me?
Yes, we can.
Yes, we can hear you.
Thank you very much. First of all, I'd like to thank for the presentations. They were excellent presentations. I still think, though, there's still a lot of confusion. A couple of the presenters mentioned the CPJE. That is a misnomer. It is not the CPJE legally. It is the California Practice Standards and Jurisprudence exam. It was developed because the NAPLEX was insufficient, and many believe it is still. With moving to standard of care, the California Practice Standards and Jurisprudence exam is an important aspect. It is 80% not law. When we ask the questions of the students, we never ask them what's on the exam. We ask the question is how much of the 100 questions or 80 questions or whatever it is, they say only about 10 to 20 at most are actually law questions. The rest are practice standards. That explains why a lot of graduates outside of California do not pass the exam. The pass rates for them are much lower, and unfortunately some of our schools. The other thing I want to mention quickly is there's a lot of confusion between the California statute and the ACP requirements. ACP requirements that were just posted do not allow any of the APPEs and EP hours to be paid hours by an employer, where California has a tradition of, quote, you've heard about the intern hours, the work hours, those were paid. There is a problem with sufficient sites. So the board needs to get clarification from the schools which of the APPE and IPPE hours are actually at work sites of functioning hospitals, pharmacies, and other places, and which of those hours are provided by the schools in simulations done at the school, and need to have a discussion of the value of each of those. So many of you know me. I worked for Kaiser Permanente for 46 years. I oversaw all the IPPE-APPE programs. I handled all the contracts. Notice that ACPE requires written contracts with every school that the board could look at. I also oversaw all the residency programs, which are postgraduate, which are licensed pharmacists when you talk about a residency. So it's very important that the differences be clarified between the law, the accreditation standards, what you mean by a student, what you mean by an intern, and which hours are allowed to be paid and which ones are not, and how that affects.
10 seconds.
And I agree with Renee. There is a very high value to having hours that are allowed by ACPE to be paid hours, because you really understand what's going on
All
when
right,
you're
and
accountable
time
to the
is
hospital.
up.
Thank you.
Thank you for the comments, Dr. Gray.
All right, this is the moderator. Next, I have a call-in user ending in 98. And call-in user, you'll be given 3 minutes to speak and a 10-second warning. I'm going to request to unmute your microphone. You're going to click *6 on your device to unmute.
Good morning. My name is Nancy Rue, practicing at Loma Linda University Behavioral Medicine Center, but I am speaking for myself. I would like to just thank Dr. Takahashi for his wonderful presentation and echo everything that he has presented thus far. Thank you.
Thank you for the comments. And I know Dr. Scott raised his hand as well, but he disappeared on my screen. So maybe he was just trying to tell us he's leaving.
This is the moderator. I don't see him in the WebEx meeting anymore, so perhaps that is the
Okay.
case.
Yeah, okay.
And
All right.
it appears we have no further requests for public comment at this time.
Thank you. Thank you, Sarah. Thank you, everyone. So members, now I'd like to open up a little bit of discussion about this topic of intern hours requirements. Appreciate the various perspectives shared in the presentations. I serve as a preceptor for many years, and to me, there is definitely a variability in skills and education of the students I precepted. And so many of my colleagues seem to agree that graduates do not sometimes appear to be practice ready, and I may question it could be part because many students do not work in pharmacies as an intern outside of school rotations, or that I also understand that schools do ensure students are gaining as much patient care experience as possible. So I'm very kind of in the middle. I do definitely would like to hear your thoughts. I also do feel genuinely that having extra experience, work experience outside of school, to me was one of the most valuable learning opportunities for me personally, and I see that for my students as well. I don't see, though, in my last comment before I open up, I don't see this as a binary choice. I don't think that this is a bring it back to the 1,500 hours work requirement versus leave it as it is. I'm thinking maybe is there some other creative, innovative things that we could think about of us somehow incentivizing pharmacy students to also be working and gaining those experience. That's kind of food for thought for me, at least. Legally and regulatorily, statutorily, I don't know what can we do. I might have to take it back and research, but with Anne and my counsel Corinne. But in the meantime, members, any closing thoughts, any strong opinions on how we proceed forward in balancing this issue? Renee, go ahead.
Yeah, I appreciated, well, your comments as always, and all the commenters. It's, very enlightening. And I would say that I would still hold that it is really such a valuable experience to be an intern. I do not think that that increasing the hours is an answer for sure. That it's a lot of hours and I know things are set, but I do agree with you that perhaps something, some creative solution. I do know that I would like to get more clarity. I don't think I understand from Stephen Gray the law versus accreditation standards and whether they can be paid or not paid. That try to understand exactly what that all means, if that applies at all to this. And which it seems like it probably does. I know that I have heard from interns, and it's been like maybe 2-3 years, or 2 years or so that I have not had interns. But it was expressed several times that they didn't think they wanted to be interns because I think sometimes people recognize that working is in a location might be a little in pre-intro or leg up into possibly applying for residency. So but they have expressed that they feel that they're not supposed to and that they might get in trouble. And I don't, it's like I don't necessarily think that's true. I think they're probably being told because of the rigor of the program. But there does seem to be somewhat of a perception of that because I've heard it more than a couple times. And I mean, although they, still worked so as interns. So yeah, I still would like to pursue. I do think there's some compelling reasons. And I don't know what that might look like. Something different. So that's what I'll
Thank you, Renee.
Thank you.
So Tinder, did you have something to say?
So thank you, President Do. I agree that I have observed, sometimes some students not practice ready. I agree with that assessment or comment. But in the absence of not any concrete data that demonstrates that there's been any improvement or decline in patient safety resulting from the regulations that we had before versus what's there now, I'm more inclined to keep it the same. But that doesn't mean that but in order to, like I said, I agree with the comment that maybe we can come up with some creative way to make sure that the students are practice ready. I was wondering if there's maybe a particular skill set, for example, maybe interprofessional communication or patient medication safety or MTM, certain skill sets where we feel like are really critical to the practice. There could be some sort of a certification of practice ready that maybe the schools could do before they become um, as a licensed pharmacist. So instead of, dictating that they need to complete X, Y number of hours, but there could be some sort of like maybe a practice ready certification or something.
Thank you, Satinder. I'm being told I missed Sean. Sorry, I thought I saw you didn't move. So sorry, go ahead. You can go ahead and do public comment. I'm sorry. You gotta move quick.
Sorry, it's always the only one here, so I'm always the first person to comment. But I echo with all the comments, but I am also an ACP provider for CEs and continuing professional development, as well as a preceptor for FEs and EPs. So comes with the mindset for some of the challenges that pharmacy schools may also see from recruitments for preceptors, as well as how to incentivize the preceptors and making sure that there's the quality of the preceptorship. So that really needs to come together in order to have the students to have a quality rotations or internship hours. And as well as we also have to account for the interstate interns as well. There will be pharmacists that coming in from the different states, or student pharmacists coming from these different states have different measurement of the outcomes. So that also comes with the mind of the what has been discussed with the generational difference that comes with the flexibility of experiential learning, because everyone has a different methodology or formats of learning. Some people may prefer remote webinar certificate or certification, but also comes with hands-on learning that we have discussed. So those have to be all counted in order to make sure that what really makes sense to provide quality education rather than enforcing what to learn, how to learn, what has to be in place. So that is a lot of responsibility for the schools as well as the preceptors to, I'm sure that also comes with ACPE standards as well as the AACP EPA that has been discussed. But I would just want to provide that perspective as an ACP provider. And thank you so much for letting me comment and having this important discussion today.
Thank you, Dr. Kim. We're gonna go to Trevor.
Yeah, I just wanted to kind of double up on what Satinder was saying. I think a kind of compromise here, going off what you also were saying, President O, is if there is a way we could incentivize versus mandate this sort of in practice behavior, because everyone's going to want to go into different practices for different reasons. And if we were to go along the route that Satinder was mentioning about a certification or an additional, incentivization that students could highlight on their resume, stating that they are practice ready for those that want to go into that sort of practice. I think by having that incentivization, it could be a good compromise to, for those really ambitious folks that want to go directly into practice. In that way, I would just, we are a comprehensive regulatory body, and we have a lot of those. And so, rather than, continuing to put on a blanket kind of mandate for everyone, I think being innovative and finding those incentives would be a good compromise to kind of make sure that we are enabling the preparation for practice-ready pharmacists, while also recognizing the many different paths that folks might take in their career.
Thank you, Trevor. All right, members. Any other thoughts before we move on? We gotta move on because we got a lot to cover. So we're gonna go take a break as we follow labor law very rigorously here. So it's 10:48. I think 15 minutes is required per my understanding. So we have to take a break. We'll come back at 11:03 or we'll do 11:05. 11:05. We'll see you back. Okay, everyone, it's 11:05. Hopefully we can get back on it. We have a lot to get to. Again, thanks to all the presenters in the prior agenda item. I appreciate it. And I see Dr. McBain still as panelist. We can probably bring her down to attendee if you can, Sarah. Okay, we're ready to move on, but we got to take a quick roll call. Trevor?
Present.
Thank you, Renee.
Present.
Thank you, Claudia.
Present.
Thank you, Satinder.
Present.
Thank you, and I'm here. All right, next agenda item 5, discussion of changes in pharmacy law included in an possible action to make a recommendation to the board regarding implementation activities regarding AB 1503 Berman 2025. As I'm sure you all know, we've worked so hard over the last 4 years on this culmination of so much work that we put into, so it is quite exciting. As included in the meeting materials, Governor signed the board sunset measure AB 1503 on October 1st, 2025. With this action, significant changes to pharmacy law will become effective on January 1st, 2026. So I'm just so proud of our efforts to pursue so many important patient safety provisions. The board's legislative report and the final outcome on the measure reflect the board's strong commitment to California consumers. I am so proud to be a member of this board and to get to work with such dedicated members and board staff. And this will be beneficial for California patients and licenses, I'm confident. As the meeting materials reflect, the board now must implement these provisions to fully actualize the important patient safety initiatives. From a process standpoint, I plan to discuss several areas of the measure and will be providing opportunities for public comment at various stages through discussion on this agendized item. So just keep in mind, we're gonna just do public comment as we go. We're gonna focus on a couple topics, then we'll do public comment, and then we'll go like that. So we'll begin with our discussion on implementation of the provision specifically related to establishing a pharmacy technician advisory committee. As the materials note, the board is required to establish an advisory committee that will be responsible for making recommendations to the board on matters related to pharmacy technicians. The law provides that the committee shall consist of 4 licensed pharmacy technicians representing a range of practice settings, 2 licensed pharmacist technicians, 2 licensed pharmacists, one of whom shall be one of us, and it shall be appointed by the board president and 1 member of the public. I agree with the criteria staff are recommending for an appointment to the committee, which is short and sweet at this point. I would agree that an online process have to be a one way to get the applications. Also, if members are comfortable, I would also suggest that we establish a term for members of the it's called PTAC, Pharmacy Technician Advisory Committee, PTAC or PTAC. I'm not sure which one's going to win over. I think it's going to be PTAC. Sounds pretty flowy. PTAC? Given members of the board serve 4 years, I suggest that may be an appropriate term for members of the PTAC as well, 4 years and renewable 1 time. I think that's probably a good starting point. One additional area I believe we need to discuss is the appointment process. Should this be something done at the board level through a public meeting, or does the board believe it is appropriate to delegate the authority to the president or to anyone else? I personally don't have strong feelings. I think it could be a mix of 2 things. So members, anyone with any strong thoughts? I also want to highlight there was a public comment posted on our website and disseminated from CSHP regarding what their suggestions. I know theirs is very lengthy, but I do think that it's good to keep the standards high. But I think what's really important is I want this to be from pharmacy technicians working on, the ground, like they're working pharmacy technicians. I really do want that to be an important criteria for me personally. Members, anyone with strong feelings, go ahead. Travel, your hand is raised, but I think that's just stuck there from the last one. So, okay, all right. Anyone? Silence
I'll
in this
go.
meeting. Okay, go ahead, Satinder.
I think we need to have I agree that we need to have a provision in there that says the current practicing for sure. And I agree that we should be consistent. I think this was also in the comment section. Do we make it consistent, similar to the board 4-year and maybe renewable? And I think maybe that they have to be, a diverse group from different practice setting, and would be that's similar to the members that we have on the board currently. I think that would serve well. And lastly, maybe some sort of a experience requirement in the practice setting, like maybe I don't know what that could be. I don't think it should be maybe extensive 10-year, that kind of thing. Maybe maybe somewhere around 2 to 4 years or something like that.
I agree.
Is my
Thank you, Satinder. I agree with you. I think 10 years a little too much,
Yeah.
in my humble opinion. I do
Yeah.
think that it's good to have newer technicians' perspective as well. So there should be some balance there.
Exactly.
Anyone else with strong feelings? If not, I'm going to assume that what we have as a meeting materials is sufficient to start. But Renee?
Hi. Yeah, I mean, I think this is great. I'm super fan of PTAC.
PTAC? Okay, fine, Renee. I guess it's
But
gonna
I guess we could decide on that, or it will just show up, but or something else. But yeah, so I like PTAC. Yeah, I mean what we have here for recommended action, I think is the absolute minimum. So but important, obviously. And I did appreciate the submission from CSHP. I think it's very thorough and well thought out. I would agree that I feel that for the pharmacy technician, a minimum of 10 years is a lot. And I would agree with Satinder, somewhere 2 to 4. I think I'd probably have a minimum of about 3 years in a consistent setting. And I also agree that it should somewhat reflect, I mean, not somewhat, it should reflect the practice positions that are on the board, because I think that does represent a lot of technician workforce. And I think that would be important. I think the functions that they do as those technicians, I mean, while there's a long list in the CSHP, which is great because those are all certainly kind of subspecialties, if you will, even in pharmacy for technicians. Some of them doing a variety of those things all the time, some of them being maybe a little elevated as leads or something, or other positions. So I think just the practice settings would be, I think, more of a priority than really looking for any exact, like what they have as their knowledge base, because I think it will be reflected in where they work. So that's the things that I think are most important. I think letters of recommendation, certainly, but I think that would be part of some type of application process. So I do think that will be important. So I think that's kind of the minimum for me on
Got
those.
it. I think I agree, and I'm sure everybody concurs with that perspective. How about the process? Because I think that we could talk about this further at the full board meeting, but also just want to get some ideas of, because I honestly, remember, just a reminder that this is 7 member, 4 are appointed by the board. one member, two are pharmacists, one of them who should be a board member, so one of us, and then one, I believe it has to be a pharmacist member, is my understanding. Anne, can you please correct me if I'm wrong? I believe it has to be among the 7 pharmacist member of the board member. And then one has to be just a regular pharmacist, and then one more is a public. That's my understanding. So we have 4 technicians, right? And so if we do pick out which category, like for us 7 of pharmacists, we have 6 of them that are designated, right? Community chain, independent, long-term care, institutional, union, and then compounding. So are we hoping for that like narrow? Should we go for more broader into each category? I think that's where we have to kind of figure that out. So if we don't have an agreement today, that's okay. We can just continue to add this and then discuss at the full board meeting when everybody's there as well. Because if you notice that I'm not trying to make everybody make a motion for committee recommendation, because it's just, this is such a fluid discussion. And so I think we're gonna go as at the full board meeting, make motions as we go so that we can just have one-time motion. So it's a little bit of fluid discussion. As you can imagine, this is a huge bill to implement. So there's a lot of moving pieces. Any thoughts on that? Go ahead, Claudia.
And just to verify, on the text, we don't have that there's a public board member, but you mentioned that twice. Is that the case, that we do have to have one public board member?
So there's 4 technicians and then 2 pharmacists, and I think one of them has to be a board member, and then the last is public member.
Yeah.
That's my understanding.
Hi, this is Corinne in the hearing room, just to
Thank
clarify.
you. Thanks,
Yeah.
Corinne. I was
So what
waiting for
this-
you.
Yeah, so the composition of the, what are you calling it? PTAC?
PTAC or PTAC. I don't know which one's going to win over.
Okay, 4 licensed pharmacy technicians representing a range of practice settings to provide a diversity of perspectives. 2 licensed pharmacists, of whom 1 shall be a member of the board and shall be appointed by the board president. And finally, 1 member of the public.
So it has to be among the 7 of the pharmacist members.
Correct.
Is what I'm getting. Okay, that makes sense. That I will be appointing. Okay.
That's correct.
So I'll have to ask our pharmacist members who wants, because I'm sorry, I would love to, but I'm not doing it. So we'll have to figure out who would like to do it. So any strong thoughts on that, members? Claudia, does that answer your question?
Well, I'm looking at the meeting material, and we don't have that there should be a public board member. We just end with one of which should be a member of the board. So I'm not sure if it matters that we should put that language into our material.
We'll make that clear. If it's not there, we'll make that clear.
Yeah, just for our meeting notes as well.
And I'm gonna guess that, Corinne, nothing is prohibiting one of our public members to also want to serve and be a public member of that committee. I mean, that seems to me a good, because there's 2 members, and
yeah,
I think
I mean,
it's not violating against the Bagley-Keene, so I think that would be a workable solution as well, if they would like to.
If they would like to, I think that would be, does the board want broader perspectives than people that are already serving on the board? I think that would be a consideration.
Okay. But I think it's a great education for our public members to serve in that capacity as well. So I think that's where then it boils down to appointment process. So before I move on from the next topic, I just want to kind of get your thoughts on, do you want this to be a public process? We could do it where we agendize it. I mean, we could have some sort of hybrid. We have to really decide. I'm very indifferent about this. So strong feelings, speak your mind, please. If indifferent, we can just table it and discuss it at the full board. Renee, go ahead.
I think some transparency as to the choice, perhaps. But I don't know about like how that could work depending on, I mean, I'm assuming there could be quite a few applications. So I don't know how that would, actually work to have a meeting, like, or if the whole thing is a meeting, but I don't know what that would look like.
That could get a little weird, right? Because we're choosing somebody in public and deliberating. I'm not sure if that is a word legally allowed to be a closed session either. So I think that's where things get a little dicey. So
Yeah, can I just jump in for just a second? I don't know, like if, sorry, and Corinne will get me. So like in terms of appointment, I think the board has like a buffet of options. And so either during this meeting or at the board meeting or, you know, whenever the board will provide guidance on it, but like, right, it could be the board president, it could be 2 members. And in both of those scenarios, I do not believe it would be done as part of a public meeting. If the board decides beyond 2 to like have it done through a committee of the board, that would be a public meeting, as well as if it decides that the full board will be doing it, that would also be a public meeting. So just in case that's helpful information.
And
thank you,
everything
Ann.
she just said is correct.
Of course it is correct. All right, members, I think we're not really solid on that, so we'll just probably bring that up for full board meeting and we'll just kind of think about what members are thinking on that time. Claudia, go ahead.
And how are we going to roll out this? I know that, you know, it's done, but how are we going to inform our potential member committees that want to join?
How are we going to inform?
How are we going to inform the public that that this is open for?
Oh, I'm sure we'll be releasing materials via the script. We'll be updating our website. We'll probably be, you know, Anne goes around, you know, many of associations, meetings, conferences, and I'm sure this will be one of the very important topics for her to highlight to the regulated public. But we'll of course release subscriber alerts. As you know, that it is requirement for licensed individuals to keep up their email address with the board. So I would that in theory, they all should be receiving their emails and not maybe go to junk mail, but they should all still be receiving emails.
All right. And how soon do we have to get this implemented? Is there a timeline?
There is no timeline.
Okay. So it's really up to us to determine how soon we want to start to put this in motion. Okay.
All right, members, we're going to go for public comment. Sacramento is empty, I believe, so we're ready for WebEx.
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, we got a couple requests. First, I have Chasney Johnson. And Chasney, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I think the Pharmacy Technician Advisory Committee sounds like a great opportunity for pharmacy technicians to come together. I would like to hear some skill recommendations during this committee, if possible, of some things that they're being seen, because some people take leadership roles and don't give suggestions or share new information they learned on their journey. For example, it would be great for pharmacy technicians or even pharmacists to advocate and demonstrate knowing the fill limits of when to fill how much pills that should be placed inside an amber vial, or when pills should be left in an original bottle due to absorption problems. In some retail stores, the production workflow is very rushed and details shouldn't be just observed in the IT verification stage. Thank you and have a great day.
Thank you for the comments.
All right, this is the moderator. Next, I have Stephen Gray. And Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you very much. I'll be very quick. I believe you should go on record to say that the terms, at least initially, should be staggered so that you maintain some continuity and history of this task force. And so please consider folding that into your rollout plan. Thank you.
Thank you, Dr. Gray. We'll have to figure that out because it's going to all start at the same time. So that'll be a little tricky, but I think we'll hopefully have something by the full board meeting. Thank you.
All right, this is the moderator. Next, I have Lorianne DeMartini. And Lorianne, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, everyone. This is Lorianne DeMartini, CEO of CSHP. Sorry, I'm fighting a bit of a cold. Thank you, first of all, for incorporating our comments into this meeting agenda. And obviously, you had the opportunity to take a look at it. I will tell you, originally, I thought about 2 to 5 years of experience, but I raised the bar at 10, and I can hear from the folks from the board that perhaps that's a little excessive. And again, we really appreciate you taking into consideration CSHP's recommendations. We have been a long supporter of advancing pharmacy technician practice, and also equally important is for them to provide informed recommendations to the full board. And thank you so much.
Thank you, Lorianne. Oh, Dr. Kim has moved to WebEx. He got tired of sitting in that room alone, so he's...
All right, next I have Sean Kim, and Sean, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hopefully you guys can hear me okay.
Yes.
Thank you so much. CPHA strongly supports, and we also echo what board has already discussed regarding the experience requirements, as well as the covering all the practice settings. We also recognize the pharmacist member will be also very important for this committee. I'll call PTAC. And for the reason is because that the pharmacists may have an experience of pharmacy technicians before becoming the pharmacist, and they'll be very valuable to provide and incorporate into this committee's work. So we should definitely think about what the purpose of the committee and what we would like to see from the committee's work. And we would also love to see the balanced representation, not only through the practice settings, such as community-based or health system, but also the geolocation, because depends on the geolocation of the pharmacy practice, it really dictates what they do in the community. So for example, CHW program is a very, very important, as it has been very highlighted through the CMS HR1. So I would like to emphasize that it would be very important to acquire.
You got cut off there, Dr. Kim.
Can you hear me?
Yep, yes,
Can you
go
hear
ahead.
me? Oh, sorry. I was just gonna conclude my comments. Thank you again for letting me comment, and we're hoping to provide any feedback from CPHA as needed.
Thank you, Dr. Kim. Thank you.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
All right, members, any comments after the public comment? All right, moving on. So we are moving on to provisions related to advanced pharmacist practitioners. Agree with the staff recommendations for implementation, and note that the implementation of the related provisions seems straightforward. All the section 100 changes, which Anne can explain a little more for any of the members who are not familiar with that. I myself am not expert in explaining that, but it is basically a process for a regulation update when it is a kind of a automatic way. So it should be quick and easy, and our executive officer has the authority to proceed on those matters. So that's what mainly with a advanced pharmacist practitioner. But we also have a discussion coming up at the later part of the day about more holistic aspect of advanced pharmacist practitioner, which we'll get to at the later part of the day. Members, any thoughts? Okay, we're ready for public comment, just related to the section about advanced pharmacist practitioner name change.
All right, this is the moderator for members of the public on WebEx. If you would like to make a comment on this item, please click the raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. And just to confirm, there are no public at the Sacramento location, correct?
Correct.
Okay, perfect. Thank you. First, I have Richard Dang, and Richard, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, thank you, Richard Dang, on behalf of myself. I think the agenda item is pretty straightforward, the name change. I was just curious if there was also discussion and consideration for what the abbreviation would be. Currently, it's APH, but I'm not sure APH matches the new title, so I'm just wondering if that was considered. Thank you.
Oh, thank you, Dr. Dang. And do you want to say something to that? Just because the abbreviation may just stay APHA just for now, but I think it's a lot of system things. But thanks for the comment.
All right, this is the moderator. Next, I have Stephen Gray. And Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. I have been asked by several advanced pharmacists currently licensed whether new licenses will be issued with the new designation. They believe strongly in this. They believe strongly in the name, and they believe that if they can officially use that new title, it will help them in their careers and their credibility. And also, a couple of those comments came from the deans of the pharmacy school, which I think was the group mostly behind changing this name in law. So I just want to add that to the discussion. Thank you.
Thanks for the comments, Dr. Gray.
All right, and this is the moderator. It appears there are no further requests for public comment at this time.
Thank you, Sarah. Okay, members. Next is, okay, just a friendly reminder as we're most likely, again, not going to have motions and stuff, so just wanted to make sure our members are aware. Next is the definition of pharmacist. Following the statutory amendment, which clarifies that pharmacists are not restricted to practicing only within the 4 walls of a licensed pharmacy, the committee may wish to consider whether it is appropriate to pursue regulations that expressly permit broader remote processing authority for pharmacists. In preparation for our discussion, I worked with staff to draft some possible language for our consideration today. I want to note that I'm not sure the regulation requires this full level of detail, but wanted to ensure that we consider items that contemplate issues raised in our prior board discussion, such as the ability for the board to conduct an inspection. Members, your thoughts? And I'm gonna today default your silence as agreement with the meeting material. So hopefully that's clear for the public record. All right, I don't see any comments on there, so we're ready for public comment.
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. First, I have Mark Johnston, and Mark, you'll be given 3 minutes to speak and a 30-second warning, or 10-second warning, apologies. Please click the unmute me button when the prompt appears on your device.
Hello, thank you, board. This is Mark Johnston with CBS Health. I greatly appreciate the removal of the restriction in statute for remote work for pharmacists, and I encourage the board to expedite rulemaking as quick as possible. I do have one comment concerning the inspection of a pharmacist's residence or location of the remote work. First off, there's very few states that don't allow remote work, so this is not a new practice across America. The overwhelming majority of the states already allow this, and very few have these inspection parameters as part of the rule. The most recent state to adopt an inspection parameter is Kentucky, and Kentucky has their inspection allowance virtually. So I thought that might be an option for the board to consider. It appears as though the new trend would be to inspect these residences because it's, there's challenges with inspecting a personal residence. Maybe virtual is an option for the board to consider. Thank you very much for acting as quickly as possible on this one.
Thanks for the comment, Mark.
All right, this is the moderator. Next, I have Jackie Stover, and Jackie, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, my apologies for pulling the trigger earlier, but I'll make my comment regarding remote processing during this first part of the meeting. So as I mentioned previously this morning, my name is Jackie Stover, a specialty pharmacist, and I'm very pleased and excited about the recent passage of AB 1503. However, I'm getting some feedback from my employer that they're waiting on the Board of Pharmacy for clarification as far as remote processing is concerned. So my question is, does the Board of Pharmacy intend to provide clarifying guidance or policy on remote processing within AB 1503? Thank you for your time and consideration.
Thanks for the comments, Dr. Stover.
All right, this is the moderator. And next I have Enos Anton. And Enos, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
You dropped off for some reason on my screen.
I will see if they pop back in later.
Let's go to Dr. Gray.
Yep. Next we have Stephen Gray. Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you very much. I'm very concerned about the proposed language in specifically most concerned about subsection B1 and which is all about remote processing of prescriptions and how the language below it in 1 might be confused about its application to Amcare Pharmacy. The term performing therapeutic interventions is often or mainly, or could be mainly, the focus of Amcare Pharmacy. And that is done remotely. And in fact, under federal law for MTM Part D, it is almost always done remotely but it's certainly done, when it's not done remotely, it's often done in a patient presence situation, which is not necessarily in a pharmacy. Could be in a clinic, could be in a discharge department of a hospital, many, many things. I'm also concerned about the includes order entry. Those Amcare pharmacists, the reason we adopted the base statute about entering into the pharmacy system was to allow Amcare pharmacists, who are the prescribers, to actually go ahead and enter the prescription with the permission of the pharmacy. That's very explicit in that statute, to enter that prescription directly into. Those pharmacists are trained often how to use the organization's system and can do it better than physicians, nurse practitioners, or others, where often we have learned not to allow them to enter it directly. So I think there might be some confusion that remote processing of prescriptions and having to do it, in a licensed inspection space would be meaning that the Board of Pharmacy would have to get involved in wherever those Amcare pharmacists are, not only, like Mark Johnson said, from home, but from clinic, from medical offices, from many different varieties. And inspecting a home or inspecting all those locations really seems to be overkill. Physicians can call in prescriptions from their car. and often do, or change or do interventions. Why would they be trusted, or from their home or from their boat? I mean, I've experienced all of those. Why would they be trusted to enter something into the medical record or the pharmacy system, which the statute allows
10
with
seconds.
permission, and pharmacists not be allowed? So I think you need to kind of rethink all of that. Thank you.
Thank you, Dr. Gray. Just for our members, just this kind of language was from the old remote processing waiver, just so we know where it's coming from. I think maybe we can take a look at, if there's ways that we don't cause confusion. But, Dr. Gray, thank you for reminding me flashbacks of the 2020s nightmares that, we had to deal with in these languages and subsequent languages related to this topic. So I think for me, I'm okay to simplify a little bit in terms of the text. We can try to bring that up for next full board meeting. I can work with Anne, but I do think that it is in terms of just dispensing functions. So I think also the inspection is that not that we are always just knock on your door and inspect. I think it's just that we want to be able to ensure there's an opportunity if we have to. So that's the idea. So any strong thoughts on this before we move on? Not seeing anyone. Oh, Claudia, go ahead. And
Yeah, I
Renee?
guess what just comes to mind too with remote processing and placing orders is the cybersecurity. I know some organizations only allow certain individuals to use their protected hardware that they provide for security purposes. So I think we should look into security and what we expect the pharmacies to provide. Because if somebody's logging in with a cell phone or with a compromised computer, it could potentially take down the rest of the system. So if we could potentially have an expert maybe help us figure this out of what we might want to require so that we don't get hacked as well. Those are just some thoughts.
Okay. I agree. Absolutely, Claudia. Thank you. Renee?
Hi. I guess well, to respond to Claudia, I feel like the that A1 in there just seems to generally cover that. The pharmacy is responsible for ensuring all appropriate and necessary security and confidentiality provisions are in place, including compliance with HIPAA and specified in policies and procedures. So if something seems to be missing from that, but I mean, it certainly is a valid point, but it's also, kind of just a general statement. And I also would be in favor of, like I'm sometimes just seeing these lists and we're trying to be less prescriptive. So, I appreciate always the statement that, and other duties as approved by the pharmacist in charge and specified in the pharmacy's policies and procedures. I don't know if that's enough to just have a statement like that, if we could possibly consider that, or if we, sometimes for clarity, people want to feel like they know that I can do these things, right? So I don't know how simplified to go with that, but could possibly be just that.
Okay, sounds good. We'll take a look and maybe update the language for the full board meeting. Also, I believe we probably want to add that it's in terms of dispensing of prescriptions. So that's probably really important for us to remind ourselves that remote processing related to dispensing. And I know a lot of ambulatory care pharmacists are not really involved in terms of dispensing of prescriptions. They're just more providing clinical knowledge, which is not part of remote processing. So I know that this always causes a lot of confusion and a lot of discussion. So I think that we can, go ahead, Satinder.
No, I was, go ahead and finish, and I was going to just have a more comment follow up on that number one. So.
Oh, yeah, no, and then I think it's just always confusing what is remote processing, all that. So I'm gonna say maybe I'll evaluate and see what, but I can at least have a draft policy statement for the intervening period because the regulation development is very long and arduous. So I think that I can work with Anne and see if we can develop a draft policy statement in the meantime. So go ahead, Satinder.
I was saying that for the inspection part, like I think having a inspect individual homes may be a overkill, like previous caller had, I think Steve that was mentioning it. But I was saying that if we require the pharmacies to be responsible for the security, HIPAA, and all those things as it is in the provision of one, and they're also responsible for inspecting the space, that they would be, um, in their SOPs. And if board needs to ever, um, you know, inspect that, they would just follow the established SOP that the pharmacies have in order to inspect that space, if necessary. Maybe we can get around that way. It could be remotely or whatever method the pharmacies have established.
Sounds good, Satinder.
Yes.
All right, members, we're ready to move on to the next. Let's see, where are we? So now next is self-assessment process. I'm very excited about these changes, as I believe the transition to statutory provisions will streamline the approval process and assist licensees in maintaining compliance with pharmacy law. If anybody wants to know the history of all these things, and can provide all the information to you, but basically now that it's incorporated into the statute, we do not have to go through the regulatory process, and that we could approve the self-assessment at the board meeting. Probably going to be done annually in January, February meeting so that we can keep it consistent. I'm also like to advising members that consistent with prior board action, anticipating the statutory change, Enforcement and Compounding Committee Chair Maria Serpa and I have been had preliminary discussions with staff on how best to overhaul the self-assessment process to simplify the process and streamline the form. So I look forward to additional work in this area, and as required by statute, the board will review and approve all self-assessment forms in consultation with the stakeholders. And I anticipate this will occur as early as board's January 2026 meeting. Members, any comments or any thoughts? I know we already talked about this in anticipation of this. Renee?
I just have to say that this is a very exciting and very welcome change. It creates a lot of confusion, and so very happy about this.
Yay, me too, me too. Okay, we're ready for public comment. Sacramento is empty, so we're ready for WebEx.
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon, or if you're an audio-only participant, you can press *3 on your device. I'll pause a moment to give the public time to access these features and submit their requests.
Friendly reminder regarding self-assessment process for our public.
All right, and it appears there are no requests for public comment at this time.
Thank you. They're all just so excited to fill out these forms. Next is standard of care. To me, the most exciting topic of the day. I must admit that to me, this is the most exciting portion of the bill. And I believe we have secured important changes to pharmacy that removes barriers to patient care in many important areas. As the meeting materials note, there is significant work to implement the standard of care provisions. Thankfully, a lot of them are Section 100 changes, just cutting across those regulation and protocols. Well, so much of the work can be performed by our executive officer under delegated authority. I believe it is appropriate to consider if releasing a policy statement is appropriate. The attachment 2B includes a draft policy statement. Hopefully, members, you had an opportunity to review that. And the hope is to keep it broad. For my own personal opinion, I really do think that this is time for us to step away from detailing out what you can do, how you must do it. And I think that in this opportunity, I also would like to bring up a possibility also looking at our continuing education regulation 1732.5 as well as part of this meeting. So just wanted to get your thoughts on that, members, and kind of see how you're thinking about our policy statement draft. Again, silence as a agreement with what's out there. So I'm not gonna force all of you to talk, but if you're like, any thoughts, please share.
I'm going to agree that we need to keep it broad. I agree with the policy statement. It's we should not be getting into like whole purpose of going to standard care was to get away from the having a very prescriptive policies and procedures and dictate what needs to be done. And in case we assume the pharmacists are trained and they've been getting this training for many years in these areas that standard of care is approved, and we should step out and let the pharmacists practice and with the with the insurance that they are trained and all that provisions are already in there so that they are held to a standard of care.
Thank you, Satinder. Any other comments? I'm sure we'll have more discussion of this at the full board as well. Renee, go ahead.
Yeah, I agree with everything that's been said, and I'm just wondering if there's sometimes just for clarity, this is just kind of a lot of text broken up, but possibly some kind of summary headings or something. I think for people to see, I don't know, I'm always a fan of that, but certainly not anything super significant. But I think some background and change it, something background changes, what's next, something like that. Just throwing that out.
Like, are you also hoping for like an S bar maybe, Renee? Do you think that would be helpful? I mean, I feel like I'm working. I don't want to work.
No. Well, I do think in S bars even when I'm home. So yeah, something like that, something just to provide the structure that's already there. So
okay, like a quick summary.
Yeah.
A quick summary really is one statement. We're gonna let pharmacists determine their practice is really the quick summary. So okay. Any other members? I'm gonna go for public comment. I would anticipate we're gonna have some public comment here, hopefully, because we work so hard to get this here. So we're ready for public comment. And all right, Sarah.
This is the moderator for members of the public on WebEx. If you would like to make a comment on this item, please click the raised hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. First, I have Richard Dang, and Richard, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, Richard Dang on behalf of myself. I just want to commend the Board of Pharmacy and President O and everyone involved in moving the standard of care forward. As President O mentioned, it's been a multi-year effort, beginning with the report, the stakeholder meetings, the report you put together, the data you collected. It's a really monumental change, and really appreciate your advocacy and your support of this topic. And I am in full support of President O's approach to the standard of care as far as not providing, specific protocols and guidance, and really deferring to the professional discretion and professional knowledge of the pharmacist in the execution of these clinical services. So thank you and congratulations on getting to this point.
Thank you, Dr. Dang. Thank you for many years of your support on this topic.
All right, next I have Sean Kim, and Sean, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you so much for the board. CPHA applauds the boards for the forward thinking and looking framework. Standard of care elevates the professional judgment and protects the patients and consumers, remove the antiquated barriers that I do not have to speak to the choir anymore. And we really recognize the success really depends on the broad public understanding and discussions that we need to have ongoing. And furthermore, So the concept is new for many of the stakeholders, not just the pharmacists. It goes across the interprofessionals as well as the payers. So there will be questions over time, but CPHA remains committed to have the steady partner and have the dialogue. So please come out to all those discussions that we're going to have, especially one in the March at the annual meeting. And so we are offering ourselves as a resource to host open forums as well as webinars or developing FAQs and resources that has been already discussed. Thank you so much for moving forward. And I know that work has to be done. And there will be more languages that we need to add on to this particular bill. But thank you again for the victory of this legislation.
Thank you, Dr. Kim.
All right, this is the moderator. Next, I have Stephen Gray. Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. I also echo the comments made by Sean and Richard. I also would like people to know that this is a multi-year process. This goes back 7, 8, 9, 10 years. Previous executive officers and previous board members, took the time to go to other states and find out what was going on and understand the movement and everything. And I just think it's a great achievement. And I hope everyone appreciates everything that the current board and the current staff leadership has put into this. As far as the statement goes, the only thing that came to mind was the board has adopted explicitly a hybrid approach by changing the definition and some of the language from pharmacist to pharmacy practice and vice versa. So you might want to put something in there that just reminds people that this standard of care isn't necessarily going to apply to all operations functions. And likewise, may not even apply to certain pharmacist activities that are of high risk where the board has to get into the details, such as sterile compounding, et cetera. Thank you.
Excellent comment. Thank you, Dr. Gray. We'll incorporate that for sure.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you so much. Okay, we're now ready to move on. Members, any comments before we move on? Okay, I don't see anyone. So we're definitely going to continue this discussion on this topic. And now next is 2 quick items. I'll consolidate that, moving to provisions related to pharmacy records. I agree that it may be helpful to develop an FAQ in this area. Members, any comments on that? Simply put, it is really like, as long as you digitize everything, everybody can be like a digitized records, not a piece of paper. So all those boxes in many of the pharmacies can technically be changed. So that's that. And then we're ready to talk about ownership prohibitions. I'm excited that the board was successful in securing these changes to kind of figure out a path forward for any owners who had some ties with the prescriber. So I agree with the identified implementation activities. Members, any comments? Seeing none. All right. In terms of the digitizing records as well as ownership prohibition changes, we're ready for public comment. Sarah?
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. And it looks like a request from Stephen Gray. Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you very much. Can you hear me okay?
Yes, we can.
Thank you again. Regarding pharmacy records, one of the problems I have come across is that the records of many pharmacies are, quote, in the cloud and or are not necessarily located, the computers, the servers are not necessarily located in the pharmacy is another way I say it. So you might want to look at the language of the current law where there is some confusion when it says, all records have to be kept in the pharmacy. And, people laugh at that because the cloud is obviously not in the pharmacy. It sounds, the second thing I'm concerned about is federal law requires backup for information that is digitalized in computers in case of disasters, etc. And a lot of pharmacists don't know that they fall under the HIPAA security requirements that require them to store records off-site and have a backup process. And so your FAQs or maybe even your regulations, I think, need to address that requirement simply because it's just not happening for many pharmacies. Thank you.
Thank you for the comments, Dr. Gray.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. Next is provisions related to non-resident pharmacies. As we begin this discussion, I want to highlight that substantive amendments to Section 4112, which among things provide authority for the board to inspect non-resident pharmacies and require that the PIC of a non-resident pharmacy be licensed pharmacist in California, become effective July 1st, 2026. So this is the only provision that I know of, I believe, that is effective July 1st, 2026. I agree with the recommendations of implementation activities, including updating FAQs to medication error reporting requirements, PIC trainings, and many of the things that we already do. We'll need to make sure we implement those changes to share this information. Members, any questions or comments? All right. Seeing none as an agreement with our so far, so we're ready for public comment. Sarah.
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. I have Stephen Gray. Stephen, you'll be given 3 minutes to speak and 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. I've already, in the last couple of days, received several calls from operators of non-resident pharmacies from across the country. And as you know, some of them are very sophisticated, like the large PBM pharmacies, or some of them are not so sophisticated. I think it would be important to develop a communication on this to go out as quickly as possible, where you fully explain to them what's required to get a license in California. Some of them, for an example, have PICs that took the NAPLEX before 2004. And does that mean they have to take the NAPLEX all over again? I don't necessarily know the answers to this, but those are the kinds of questions we're getting. And so I think that they're concerned that the delay, which I think is intended to allow them time to implement this by getting those pharmacists licensed, if someone has to go back to pharmacy school in order to take the current NAPLEX, that might be problematic. They also said, well, can I have a PIC who is our PIC, but then I have a more recent graduate who is taken the current NAPLEX and gets the license as the California designated PIC? And I don't know the answer to that either. It depends on board policy, of who's really the PIC and who you're going to hold responsible. Those are the thoughts that come to my mind. So I just want to alert that there are a lot more questions. I think those pharmacies that contacted me and many others are eager to comply. None of them said, that they wouldn't comply or they were going to resist or whatever. But I think that there needs to be some information go out soon so they know what they got to do by July 1 of 26. Thank you.
Thanks for the comments, Dr. Gray.
All right, this is the moderator. Appears there are no further requests. Oh, I apologize. We actually just got one right now. I have Rachel Tags, and Rachel, you'll be given 3 minutes to speak with a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hi, this is Rachel Tags. Can you hear me okay?
Yes.
Yes, we can.
Perfect. Yes, I would just like to reiterate what Dr. Gray said, especially regarding the PIC requirement. If it needs to be the home state PIC that applies for licensure, or if any pharmacist at the facility could take the test and become the California PIC. So just clarification around that would be very helpful.
Thank you for the
Thank you.
comment.
All right, and this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. I think in terms of communication, absolutely, we need to really highlight this and try to reach out to our non-resident pharmacies via subscriber alert and many other ways, script. But also regarding the PIC, I'm going to go out on a limb and say that I don't think the law specifies that a home state PIC must be the PIC for California. I think that what we care in California is that the PIC has a vested resource and the authority by the businesses that they are able to function as a PIC in terms of dispensing prescriptions for California patients. And I think that's what matters the most. We could try to release this in an FAQ, kind of a statement or some kind of a clarification. If the members are agreeable to that, we can probably bring something up for our full board meeting. But I think it's silent, and so I think it's up to the business to decide how to proceed. However, that it is probably important to remind our businesses that PICs must be vested interest in terms of their ability to really dispense prescriptions for California patients and be able to follow all state federal regulations. So, any other comments, members? Seeing none, we're ready to move on to next topic, which is I'm gonna combine some of them. So related to change in pharmacist to pharmacy technician ratio, I agree that updating the FAQ is appropriate. Any thoughts on that, members? Okay. And again, agree with the recommendation to develop a sample notice that a chain community pharmacy must post to provide information on how to file a complaint with the board. If there is an agreement, I believe this work can be performed by the Communication and Public Education Committee. Again, it's a sample, not what you must post, but the sample. And I know that there's an FAQ being updated from the Enforcement and Compounding Committee related to these provisions which we'll be discussing tomorrow in terms of the requirement part, which that's our updating FAQs that we'll talk tomorrow. So lots to cover there. Any comments on that, members? I know you're probably like so tired of this because it's so much topics, so many things going on. Also, I believe it is important to highlight and to have Communication and Public Education Committee continue to reach out and highlight this updated provision related to PIC staffing authority. That reminder, effective January 1st of 2026, PICs must determine staffing, and a friendly reminder, our professional conduct code specify any activity to subvert the efforts of a pharmacist in charge to comply with laws and regulations or exercise professional judgment or make determination about adequate staffing levels to safely fill prescriptions of the pharmacy or provide patient care are considered unprofessional conduct in California. So with that, members, any comments?
I just had a comment about previous one. That will be the ratio provisions go into effect on January 1st.
Right, ratio provisions January 1st.
We're just talking about the FAQ clarification providing.
Yep.
Got it.
And ratio has to be determined by the PICs. It's not automatically 1-3. Again, that's the part where it's always a nuance in the law. Ratio has to be determined by the PIC, and that is up to 1-3 if determined by the PIC. Okay, I'm sure there will be FAQs on that. So in terms of ratio, the notice, and staffing, do we have public comment? Sarah?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. I'll pause a moment to allow the public time to access these features. All right, and it appears there are no requests for public comment at this time.
Okay, thank you. All right, and the next is about the authorized duties of a pharmacy technician. So that area, I believe we need to update FAQs. So that is again, allowing pharmacy technicians to be able to perform certain functions outside of 4 walls of pharmacy. And any members' comments on that? None? Okay, we're ready for related
Just
to. Go ahead, Claudia.
quick question. Can you just specify a little bit more outside the 4 walls? So just a couple scenarios where that could take place?
Sure. So in our law right now, again, highlighting that I'm not a lawyer. In our current law, my understanding is that a pharmacy technician providing immunizations outside of 4 walls of pharmacy would technically be considered not allowed. And so throughout the process of education and learning, that we learned that pharmacy technicians are valuable in being able to help pharmacists immunize at such as flu clinics, at company, right, gatherings. And so it is helping pharmacists to really be able to focus on providing clinical information, right, about talking about flu shots, not just about the injecting patient or COVID vaccine. So with our amendment in our sunset bill, the pharmacy technicians will be able to allow to be immunizing flu shots and COVID shots outside of 4 walls of pharmacy. Also through the sunset process, what we learned that pharmacy technicians oftentimes are involved in compounding, but not within the 4 walls of pharmacy. And what we want to do is to have pharmacist oversight of those functions that they're performing. So we wanted to include that. And so pharmacy technicians can perform compounding outside of pharmacy, but also that they're able to do so under the provision of under the supervision of pharmacists.
That's right. Okay. Thank you so much.
Of course. Did I miss anything, Darian? I'm sorry, I'm just yapping away over here.
Nope.
Okay. All right, we're ready for public comment on that. Let's pause and do public comment in terms of pharmacy technician functions outside of the walls.
All
Sarah.
right. This is the moderator. For members of the public on WebEx, if you would like to make a public comment on this item, please click that raise hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. I've got Stephen Gray, and Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you again. I admire the board taking this on. It gets very complicated. For the benefit of some of the public members, you know, a lot of pharmacies, and you've seen this, when they go into a pharmacy to get a vaccine, the technician can come out from the, quote, 4 walls of the licensed pharmacy into the OTC area where a room or a screen has been set up to administer a vaccine. So technically, that technician is outside the walls of a pharmacy. I mean, it gets as simple as that. And then the compounding was mentioned. When in a hospital, a pharmacy technician is helping in a satellite pharmacy to distribute unit dose or do other activities, they're outside the 4 walls of the licensed pharmacy. They're not necessarily outside the hospital. And then lastly, if you look at 4071 about who can remotely enter information into a pharmacy system with permission, it talks about persons licensed in Division 2, but that didn't include pharmacy technicians, even though they're licensed in Division 2, because the definition explicitly said that you weren't a technician if you were outside the pharmacy. So all of those things may need to be addressed in communication and FAQs, because that prohibition on technicians working outside a pharmacy has been around so long that it's ingrained in the bedrock of most pharmacists' understanding. Thank you.
Thanks for the comments, Dr. Gray.
All right, this is the moderator. Next, I have Sean Kim, and Sean, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. CPHA supports the modernizing technicians' practice in acute inpatient hospitals or ambulatory care settings as well. The evolving role of the pharmacy technicians is clear signal of the profession's evolution, bringing pharmacists to focus on clinical care while maintaining the patient safety. The proposed framework allowing PIC to directed and policy-driven expansion of non-discretionary tasks within the hospitals aligns with the California standard of care model that we've been discussing. So I think this will be the vital role for the PTAC that we've been talking previously, and hopefully PTAC can translate this more into the practice model that we are aiming for in the future. Thank you.
Thanks for the comments, Dr. Kim.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you. Okay, members, I'm going to take a little pause. Any thoughts here before we move on any topics? Talked about a lot. Okay, so next, this is the last three for this agenda item. So plan on consolidating the last three subjects. These are the easy topics. So I agree with the recommended implementation related to the new provisions for an individual to restore their retired pharmacist license, as well as the recommended implementation activities related to the higher fine authority for mail order pharmacies. And lastly, the board's authority to waive fees for a pharmacy providing in-person patient services in a medically underserved area. I'm honestly very happy about this. I hope that this will at least do a little bit of help in terms of pharmacy desert in California. Sometimes we often forget how remote some parts of California can be. I'm guilty of it because I've never been. And so I know that it is definitely hopefully going to help the pharmacies to, entrepreneurs out there, pharmacy application fees and renewal fees are waived if you're the only pharmacy within a 50 road miles from that area, wherever you are hoping to open a pharmacy to provide in-person patient care services. Members, any comments? Okay, I'm ready for public comment. Sarah?
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio only participant, you can press *3 on your device. I'll pause a moment to allow the public time to access these features and submit their requests. All right, and it appears there are no requests for public comment at this time.
Thank you, Sarah. Okay, so that is, I believe, it. We went through this way faster because all of you are very generous in terms of, providing your support for what our recommendations are. So we have a few things to take it back, work with staff, and bring it for the full board to talk about and finalize. But in the meantime, I think it's just one last opportunity for members of the public, since we had quite a, we zoomed through this meeting really fast. So anything related to AB 1503, I want to be able to open up for the public to comment. So anyone in WebEx, just lasting comments related to AB 1503 in totality, please feel free to speak. Sarah?
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and I got a request from Sean Kim. Sean, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you again. Thank you so much for all the work from the board staff and the board members for putting all this legislation together. It went through many of amendments, and I think we are in a much better place to practice in California. One comment that I want to make is I also applaud Dr. Rita Shane's contribution to this bill regarding the high-risk patients with the discharge, which we haven't really discussed throughout today's meeting because of the other agenda items. But I think it'll be also vital to connect the dots, and this will be very important to the care coordination and transition of care. So hopefully that will also come to the fruition as Dr. Shane has been advocating for the sorry, I'm losing my thoughts as I'm speaking, but it'll be very important to implement it into the practice. So thank you so much for letting me comment.
Thank you, Dr. Kim. We'll definitely update that as well and incorporate that into our full board meeting. I think that is an extremely important aspect of this bill as well.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. Okay, members, any lasting thoughts on this AB 1503 before we go? Okay.
I have just a question. Yeah, what is the sentiment from the legislators? I know, I mean, everything's moving forward, but are we still getting good feedback or any pushback? Anything that we should be aware as a board? In addition to what we're seeing today?
Sure, Anne, do you want to speak on that? I think honestly, I guess I'm biased. I think we do an amazing job. Our staff are truly amazing. I cannot say enough how we are so fortunate to have our executive officer, deputy executive officer, to our chief of enforcement, Anne, Julie, Janice, just Cheryl, wonderful, wonderful government public servants. Like, they're the definition of public servants in my eyes. It really makes me feel comforted to know that those are the people that are out there running our organization and providing day-to-day operation. So with that, Anne, do you want to say anything about Claudia's comments? From my understanding, I think we're okay.
So now that the legislation, has been signed by the governor, we're moving forward with the implementation activities. We will be keeping the consultants apprised from the Senate Business and Professions and Assembly Business and Professions committees, keeping them apprised of the, of the implementation activities as they are undertaken. So, as we meet those different milestones, we will information to them.
Thank you. Thanks, Claudia. Thanks, Anne. Anything else, Claudia, for our staff on that?
No, thanks for all your work. I echo your sentiment.
Thank you. All right, guys, so we're ready to move on to the next agenda item. It is 12:22. Can staff remind me, do we have to take a lunch by 1 o'clock-ish to be most kosher? So I think
yes, I believe you have to start it by 1 o'clock.
Okay, can we proceed, members? Are you okay proceeding? Because I know Trevor has to leave at 1:30, so I would like to cover as much as we can. The next two agendas may be quick. So are we good? All right. We're proceeding to 1. Next agenda item is 6, discussion of California Code of Regulations, Title 16, Section 1793.8, technicians in hospitals with clinical pharmacy programs, including possible action to make a recommendation to the board regarding proposed amendment to Section 1793.8. As included in the meeting materials, we'll continue our discussion on the important role pharmacy technicians play in hospitals. The meeting materials highlight several relevant provisions of pharmacy law, and a brief background is provided reminding members about the actions the board has undertaken to evaluate the critical role pharmacy technicians play in supporting pharmacists and the changes made to the authorized functions of pharmacy technicians. As you may recall, during our last meeting, we received several presentations from health system pharmacies describing how each use pharmacy technicians in non-traditional ways. Following the presentations, it appeared appropriate to discuss pursuing regulation changes to incorporate these additional non-traditional roles that expand the non-discretionary tasks pharmacy technicians may perform in hospital. I draw your attention to attachment 3 to the meeting materials, which includes proposed regulation language to incorporate changes and develop a regulatory model to allow for hospitals, pharmacists in charge to determine additional non-discretionary tasks that a pharmacy technician may perform in a hospital with a clinical pharmacy program. I agree with the recommendation and the way the staff have developed the approach, and would appreciate your thoughts on the proposed regulation language. A reminder, we're not soliciting motions, as because there's so much information, I do really want this to be more of a holistic discussion also at the full board level. So I just want to remind our members, I do not need any motions, but if you are in agreement, it would be helpful to know that you are agreeing with the draft language. Members, any comments? You can just give thumbs up as well. That'll speed up the process.
I'm in agreement with the draft language.
Perfect. Thank you. Renee, I know you live in the space, so just not to try to put you on the spot, but if you have any comments, you don't have to. Just wanted to give you the opportunity.
Yeah, no, I think having it be broad, because they're, the expansion of technician roles is taken off. And I just, noting that while because like the tech check tech, it's removed, some language removed, but it still is here, because I feel like that is one thing that maybe is not, like other, like as a non-discretionary task. I feel like that doesn't fall under that, because it's, it's the tech checking the tech, like eventually there's non-pharmacists. So, but it still is listed. So even though it's removed in some areas, it still is as that, if you use this, then you have to demonstrate, the following things, like in C.
Right.
So
exactly.
I think that's great that that's still there. I know we're trying to be less prescriptive, but I do think that that
you
function.
actually, okay, you're actually agreeing that that is good that it's there. Okay.
Yes.
Okay.
So just wanted to say that.
Perfect. Awesome. All right, members, we're ready for public comment. Could be moving fast. All right, members of the public, it is open for public comments. Nobody is in Sacramento, so we're proceeding to WebEx. Sarah?
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raised hand icon. Or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. I have a request from Lorianne DiMartini. Lorianne, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hello again, Lorianne DiMartini with the California Society of Health System Pharmacists. I have to say, when I saw this, I was hooray. This is an amazing opportunity to allow for the pharmacist to use their professional judgment to determine what those tasks a pharmacy technician will do. And it is representative of the progressive nature that I've seen with the Board of Pharmacy, for which we're incredibly supportive of. It also allows for flexibility within the health system to embrace emerging practice models to meet the needs of our patients. And our patient mix changes, and it has changed over the decades that I've been involved in health systems, where the acuities only increase. So this gives the pharmacists and the health systems the opportunity to meet those emerging type of patient care and healthcare models. So thank you so much for the opportunity to provide comments and for the consideration of supporting this type of allocation and duties for the pharmacists. Thank you.
Thank you, Dr. DiMartini.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. All right, members, any other comments before we move to the next agenda item? We're moving through this part way faster than I anticipated, so that's good. All right, we're ready for agenda item 7 then. Discussion of pharmacist to pharmacy technician ratio in the inpatient setting, including possible action to make a recommendation to the board regarding proposed amendment to CCR Title Section 1793.7, requirements for pharmacies employing pharmacy technicians. So as you may recall, again, from our last meeting, I remind members that in 2024, the board released a survey related to the pharmacist to pharmacy technician ratio. The results were discussed during the July 2024 licensing committee meeting. The results differentiated the data between the institutional, aka hospital, and non-institutional setting, aka community, in broad sense. Because the ratio in the non-institutional setting was set in the statute, the board prioritized the assessment of the ratio in that setting to meet timing of the sunset review process. Today, we begin our review of the ratio for the institutional setting established in the board's regulation. The pharmacist to pharmacy technician ratio is a critical component in ensuring both operational efficiency and patient safety within hospital and health system pharmacies. The board's regulations have established a fixed ratio. During our June 2025 meeting as a committee, we reached consensus that the board should consider providing a greater flexibility for hospitals to establish the appropriate pharmacist to pharmacy technician ratio. Attachment 4 of the meeting materials includes proposed regulation language addressing this. You'll note that the proposed language takes an approach that will allow the PICs to establish the appropriate ratio with no limitation. Such an approach appears generally consistent with the PIC delegation authority to establish a ratio in the community pharmacy setting. The proposed language also includes some non-substantive changes to reflect updates in some state department names. Lastly, it was brought up last meeting, so just want to highlight that the current and proposed language is clear that the ratio is only related to, quote, in connection with the dispensing of a prescription, end quote. So hope that is clear for everybody. Members, your thoughts? Again, silence, I can take that as an agreement, unless you have any amendments you want to brought. You all are easygoing today. Thank you. Appreciate that. Renee, thank you. Go ahead.
Yeah, I just want to say I just really support this to be, at the discretion of the PIC, because there are so many functions for technicians, and just a set ratio just does not cover all practice settings. So I think it's great.
Perfect. Thank you, Renee. Alrighty, I think we're ready for public comment. Seeing nobody is in Sacramento, we are ready for public comment. Sarah?
All right, this is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raise hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. All right, I have a request from Lorianne DeMartini. Lorianne, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hello again, Lorianne DeMartini with CSHP. Thank you for this proposal. On behalf of our members, we support this proposal. Thank you.
Thanks for the comments, Dr. DeMartini.
All right, this is the moderator. Next, I have Stephen Gray. Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. I find it refreshing and interesting, Dr. O, that I did not attend the last meeting, but you just mentioned that the ratio only applies to the dispensing of a prescription, unquote. And that is true, that the language in 1793.7 says in connection with the dispensing of a prescription. But I do think that there is still confusion out there. A prescription is usually defined as a drug that is dispensed directly to the patient for self-administration. The common term for something in the hospital when they're sending something that will be administered by a nurse or other practitioner, that's called an order. And a lot of hospitals still believe that the ratio applies to anything related to the distribution of an order for subsequent administration by a nurse to the patient. So there may still be some need to clarify this, which way you mean that. So as I read this, and with your statement, it would only apply to discharge prescriptions or past prescriptions, and that all other uses of pharmacy technicians in a hospital would not even have a ratio controlled. Thank you.
Thank you, Dr. Gray, always for your insightful comments.
All right, this is the moderator. It appears there are no further requests for public comment at this time.
Thank you. With that comment, I can work with Anne and our council to see if we can ensure that clarification of that statement is possible since we are reopening up the 1793.7. I think that would be a great opportunity for us to maybe add words to clarify that section. Members, any comments before we move on?
I really appreciate the public comments, so thank you again.
Thank you, Claudia. Okay, we're zooming through here. Next, may not make it till 1, but we're going to try. We're going to start agenda item 8, discussion of proposal to establish definitions for pharmacies based on business model. As included in the meeting materials, generally, the requirements for pharmacies apply equally among a variety of business models, unless otherwise specified. This approach allows for broad regulation, yet can become challenging when business models vary, but requirements many times do not. So within the existing law, there are several instances where a more specific definition is referenced, but only when applying to a specific provision of the law. The meeting materials also provide an example. Pharmacy law does not currently include a general definition of a chain community pharmacy. Rather, in specified sections of statute and regulation, the law refers to BPC Section 4001 for definition. Note that BPC 4001 provides for the purposes of the subdivision, a chain community pharmacy means a chain of 75 or more stores in California under the same ownership. And an independent community pharmacy means a pharmacy owned by a person or entity who owns no more than 4 pharmacies in California. Different jurisdictions nationally have taken varying approaches, with some jurisdictions, such as Texas, issuing separate licenses for different classes of pharmacy licenses. On the other hand, Nevada issues a single pharmacy license that covers a variety of different types of business models. Nevada requires disclosure of the types of services, though. I believe there are pros and cons to establishing more further definitions based on business model. I personally have stated many times, I'm a proponent of maintaining somewhat of a broader licensing scheme, but also understand the value in developing definitions at least that could result in more precise regulation or statute in terms of pharmacy requirements. So members, this is where I kind of need your help because this is just an open-ended kind of a discussion, just kind of wanted to get your thoughts. It could be as simple as developing a definition via statute or regulation, starting there and in our future discussions. Trevor, go ahead.
Yeah, I would like to hear from staff about their opinions on how doing additional buckets would impact their work. I know they work incredibly hard, and we're always looking to fill positions. And I love seeing the incredible work that's being done on approving licenses and making sure that's a speedy process. My concern, I mean, on one hand, I love making sure that we are being, very laser focused on types of businesses to make sure that we're not letting anything fall through the cracks. At the other hand, I want to make sure that the board as a whole is still able to operate efficiently in that adding these additional definitions won't bog down the entire process. So I'd be interested to hear from staff of how, if we were to start moving towards this movement of more definitions for specific regulations, how do you feel it would impact your efficiency? What costs do you expect it to increase or decrease if we're bringing in different kinds of fees? So that's kind of the focus of my thoughts.
Thanks, Trevor. Anne?
Yeah, so a few thoughts. So I think it probably depends on where the board lands, and I know that that's not a super helpful answer, but I think in a lot of respects, sometimes our work is a little more challenging because we don't have definitions, so we're not as specific in some of our regulation. So I think that, you know, definitions would probably be helpful for us at the staff level. You know, if the board wanted to go beyond definitions and establish different types of licenses. That's probably, you know, absolutely executable. Let me be like super clear. We can do anything, right? You give us what you want and we will go forth. I would say that that would probably have some additional workload up front while we're establishing the new licensing categories. But again, you know, it's really about the policy of the board. But I would say at the staff level, I do think that, you know, there are sometimes challenges created because we don't necessarily have some specific definitions, and with that then sometimes creates some confusion. I don't know that I answered, Trevor, sorry.
No, that's great, thanks. So Sung, with your thoughts on this, are you envisioning both new definitions and new licenses, or are you looking at just new definitions for now? What are your thoughts on that?
Thank you, Trevor. I'm happy you bring this up because I think so. There's many. And says buffet. I don't know about buffet. Quality of buffets these days has gone down, so I don't know. Maybe buffet is not the best analogy. So I think we could look at it as so currently, just to provide a little background for our members and the public, right? So we have, in general, unless you're government owned, in California, you're a pharmacy. In most pharmacies is PHY, right? Any outpatient mail order, it's kind of PHY. And then any hospital pharmacy is HSP. And that really is the ultimate two buckets in California in terms of license. And so what we can look at is we can see, is there an opportunity and value in actually dissecting that PHY into a different license category? That's one, which I personally think that's not worth of our time. That's my opinion. Another approach is at least leaving as PHY, but that we either do a requirement for disclosure of what the business practices are and what kind of regulations they would fit under by adding a further business type or category they belong. And so if you are in this business category, these are the regulations that are relevant for you and the statutes, so that it is a little bit more streamlined for us, for inspectors, for regulated public, and to the consumers, knowing that, okay, no, this is a PHY, but this PHY is actually a closed door pharmacy. You cannot actually knock on their door and show up at the door. This is mainly a compounding pharmacy for veterinarians, so that, you know, you're not really going to be able to get your ordinary license or pearls there. This is a chain community pharmacy, so you follow in this bucket. So that's kind of what I'm hoping to achieve, so that it is good for both the licensed regulated public to be able to meet the requirements they meet, but while also ensuring that our public can know what they are, so that you have more expectation. They're a mail order pharmacy, so you're not going to just show up at their door and expect someone to open the door. So I hope that kind of makes sense. Or we can just leave as status quo and not take any action. That's also an option.
Yeah, and the way my non-pharmacist kind of semi-tech based perspective is, like, I'm looking at this almost as like better data labeling, right? And so you're even if we're not putting a specific license on these, it just allows for greater identification within our own systems to better cultivate both resources and communications and whatnot. I guess part of my one question is, do we need a regulation or legislation to do that? Is that something that the staff could just do internally and have that labeled internally? Is there a regulatory reason we would need to pass an actual, like, you know, labeling for these sorts of things? Or is this something that staff could potentially just do on their own?
And I'm gonna guess that we're probably gonna need to have statutory
Yeah,
change, but
this is Corinne. I mean,
yeah.
I would just chime in to say that I think if you were going to be layering on any additional requirements for different types of business models, that would be something you'd want to do, you know, with clear authority from a statute or a regulation, not something that could just be implemented without that.
Mhm. Okay. Yeah, I mean, in concept, this is something that I'm comfortable with. I mean, for me, the goal is always never creating a process for the sake of process, but creating a process for the sake of efficiency and greater delivery to both the regulated public and to the general public who are working to protect. So, focusing in that kind of line of thought, I'd definitely be supportive of going down this route and figuring out if this process is something that can make for not simply another layer of additional complication, but a way that we can utilize it for greater efficiency and communication.
Thank you, Trevor. Satinder, Renee, Claudia,
Yes.
any comments?
I think I like the fact that it would provide a consumer a better understanding of services that it provides if there was a different classifications. So that point is, well, my concern question would be like, how would, like, if we change the classifications as some of our regulations imply to a particular practice, like for example, community, we have ratios and those kind of things, how would that would have to be also changed in some ways, or this could impact, like obviously those practices are different, and now trying to fit some of these regulations to those business models, it doesn't make any sense. Like, centralized pharmacy is a totally different um, you know, operation than it is a community pharmacy or chain pharmacy. Trying to have those, like, what I'm just, I think we
And,
would be going that route too.
and I think that, Satinder, is the key question of what we would like to do at the board, and where we have to decide. So Anne, do you want to respond to that? Because I think it might be helpful to kind of discuss your perspective in terms of, I think we're more leaning toward not having a dissected license category, just leaving it PHY, but also is there a plus alpha that could guide regulated public and the consumers, help navigate receiving better care. So go
Yeah,
ahead.
so I guess what I would say is if the board is inclined to go like the definition approach, right? Then I think that probably the easiest way to kind of like maybe blend the two concepts would be that you would be starting the definition, and I'm not an attorney, so sorry for all of this, but like you would start it as like if you were doing a definition of, I don't know, mail order pharmacy, right? You would say a mail order pharmacy is a pharmacy that, and then you're defining it so that it will all continue to fall within the pharmacy bucket. But then when you are doing then regulation, right, you might, this is just a stupid example, but just roll with me here. You may want to say that, they don't need the notice to consumer poster, right? Whatever, does not, does not apply to a mail order pharmacy. It's a stupid example, but hopefully you're picking up what I'm
Great
laying down.
example, Anne. It's a great example.
Yes.
No, that's exactly the purpose of this discussion, is that exactly that you brought up, Anne. It's because right now, right, like, I think it depends on you which lawyer you talk to about that poster. But so that's exactly, I think, why we're having this discussion, Satinder.
Yeah, I think that kind of, it makes sense. Like some of the rules don't apply, like having
Right.
a closed door pharmacy, having a consumer poster, it doesn't serve anything yet.
Exactly.
Inspector can walk in and say that, hey, you do require it.
Yeah.
Well, I mean, it
Claudia?
wouldn't be Yeah, I mean, it wouldn't be a consumer poster, but we have to think of other ways that the message can get out, right? Based on how they're interacting with the public. When you
Yeah.
say mail order, they're just fulfilling the orders, but they're also sending instructions and indications of how to use the medicine,
There,
right?
there are required notices to include in part of the mail order prescriptions for mail order pharmacies already. But again, that's not clearly laid out in regulation, right? In our regulation for consultation regulation, it just says that if you're mailing a prescription, it doesn't say for mail order pharmacy. It says if you're mailing a prescription, you must include the notice to consumers in the mail that you have an entitlement, you are entitled to pharmacist consultation. So I think what Anne's approach is kind of to clearly laying out if you define yourself as a mail order pharmacy. And I guess I just want to put it out there that I think one business can be more than one. So I think that might cause a little confusion, but that's what I'm hoping to do is like mail order pharmacy doesn't have to always be a closed door pharmacy either. So that's when things gonna get a little complicated, which is why we have left not going down this path for a long time in California as well. So a lot of food for thoughts. Maybe we can hear from the public. I'm not sure if public has any opinions. Renee, go ahead, and then we can open up for public comments for
Yeah,
anybody with their thoughts.
I think, yeah, I mean, this is this would not be an easy process, but I do think clarity is key, right? It is not clear now. You know, like the types of pharmacies that somebody is just because they have the same license. I would agree with keeping the same, like, you know, at the top level, the same licensure, right? But because pharmacy has like so many different types of pharmacies, and having more definition around that, and granted, there's going to be some crossover, right? But there will be some who are strict, some who are hybrid, but like some of those requirements just don't make sense in all areas. So yeah, so anyway, I definitely would be a fan of pursuing this more for clarity for pharmacies, and then also obviously for the regulated public.
Sounds good. Okay, I think we're going to open up for public comment just to get some thoughts from the public. Hopefully there are. Sarah?
All right, this is a moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon, or if you're an audio-only participant, you can press *3 on your device. And I have a request from Chasney Johnson. Chasney, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I think the chain community pharmacy definition Song O used was great. The 75 pharmacies or more. Some pharmacies are held within a store, but everyone should clock in with standards to hold. Some concerns that I have having the opportunity to work both on the sales floor and inside the pharmacy is vendor drop-offs. Vendors should know to check in and be aware of all emergency equipment located inside the business, including rest areas in case of an emergency. That way, pharmacists have opportunity to climb the ladder to have oversight over the whole store. So simple things like greeting customers and other staff members by saying, "Hello, my name is Chasney. I am the style consultant of Target," or answering the phones within 3 rings with proper greetings as well. This is taught in basic healthcare trainings. That way, a pharmacist can have broader store management, and when businesses are not meeting quotas or upholding basic needs, human resources will have material to reflect back on. And if anybody doesn't have a healthcare license, food handling trainings don't usually go over these type of techniques. So that was one of my feedbacks that I would like to give today. Thank you.
Thank you for the comment.
All right, this is the moderator. Next, I have Stephen Gray. Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. my history is I was responsible for all of California for licensing pharmacies for Kaiser Permanente. Kaiser Permanente is a very broad program, has different types of pharmacies. I think there should be some effort to look at places where there's confusion. Maybe you can resolve the confusion by changing the wording without necessarily changing the licensing. And I think a detailed analysis could go through there, and I can give you some examples. The board already has different licensed pharmacies that versus community and hospital. Remote site dispensing pharmacies is a good example. A drug room is a place that fits the definition if there's a pharmacist there actually practicing in that less than 100 bed hospital, because it has the practice of pharmacy and they do dispensing. The definition itself needs to be clarified, because the board licenses clinics, pharmacists work in those clinics. They do get involved sometimes in compounding and dispensing. So therefore that would fall under the definition currently of a place licensed by the board where the practice of pharmacy is done. So, there are some places. In the definition of a chain versus an independent, there's some confusion. One section says a chain is 75 or more. The independent says it's up to 4 pharmacies. So we always ask, what happened to 5 through 74? What is that? Is it a chain or is it an independent? And so that alone needs to be clarified, because now there are penalties and there are other aspects that apply to chains and not to independents, and vice versa. There are delivery you talked about delivery. Pharmacies during COVID went into curbside delivery. So they said they didn't have to give consultation. All they had to do was give a phone number to call back. But is it really a mail order pharmacy if you're just sending a clerk out to hand a bag at the curb like they're going to Target to pick up an order or something? So there are some places where there needs to be clarity. Texas, I don't like that model. The last time I checked, they had 8 different classifications of pharmacies with different license, and 7 different ratios at that time for each one of those. Thank you very much.
Thanks for the comments, Dr. Gray.
All right, this is the moderator. Next, I have Brian Kawahara. And Brian, you'll be given 3 minutes to speak and a 10-second warning. Oh, 1 second. Let me find you in my attendee list again. Okay, thank you. Please click the unmute me button when the prompt appears on your device. All right, and Brian, looks like you're still muted. I'm going to request to unmute you. Please click the unmute me button when it shows up on your device. This is the moderator. I'm going to try one more time to unmute you. It looks like you're still muted. So let me click the request to unmute.
Hello?
There you go.
Now we can hear you.
Great. Thank you very much for the opportunity. And I think this is a wonderful idea. Quick question. How would you be handling something where it's an unmanned thing like what Amazon is talking about, putting these little vending devices around places like clinics and the like in regards to finding whether it's a pharmacy or not?
Thanks for the comment, Brian. Again, usually this is not a Q&A session, but I think that is a part of, you might want to look at the ADDS sections of our law and the FAQs in terms of that. Yeah.
Thank you.
All right, well, there are no comments. So members, I do think that it is time for lunch. So we will take a lunch break and we'll come back at 1:45. Just before we go to lunch, just wanna, anybody has any lasting thoughts on this agenda item 8?
Sung, I just wanted to note that I will not be back when we return to session due to a
No worries. Thank you.
previous appointment. If it ends earlier, I will hop back on and be back.
No problem. Thank you, Trevor. Members, any thoughts before we go to lunch? You have to come back. Sorry, we have a couple more things. Just a general announcement that I would like to also make the participants know that because of time constraints, and then also because of significant recent legislative changes, we are not going to be discussing agenda item 11 related to the survey results. So we're just going to come back and start the discussion for agenda item 9 when we return at 1:45. We'll see you back. Enjoy your lunch, everybody. 1:45. Let's get started again. I know Trevor's gone, so checking in with Renee. Renee may not be back. I'm gonna go to Claudia.
I'm here.
Oh, there you go.
It's
Hi,
Renee.
Renee.
Present.
Hi, Claudia and Satinder.
Present.
Thank you, Satinder. All right, everybody, let's get started here. Starting here with agenda item 9, discussion of infusion center pharmacies, including discussion of possible changes to pharmacy law to create a new licensing program. Piggybacking on our previous discussion on agenda item 8, this is something that we are going to discuss today. So the meeting materials detail the relevant provisions of pharmacy law related to this agenda item. In my opinion, infusion center pharmacies are a unique business model in which patients go to an infusion center for infusion of their medications by an authorized health provider. This specific business model is currently required to generally meet all of the requirements established for a community pharmacy. So that's kind of why we were discussing agenda item 8 and this agenda item. Piggybacking again, so to the prior agenda item, I believe infusion center pharmacies may be an instance where establishing a new license type, or again, figuring out in totality with the agenda item 8 and figuring out a path forward so that they are not supposed to, they're not required to meet certain community pharmacy regulations or requirements. So that it's more targeted. Just keep in mind that if there are any specific burdens faced by infusion center pharmacies, as they are currently licensed as PHY, and what provisions of laws or regulations we can change that would be helpful to provide streamlined patient care to our regulated public, we would appreciate your comments and thoughts. So members, any comments on this? Just to kind of start there. Anybody with any thoughts on this topic? I think from our previous discussion, we're leaning toward not adding a license category, leaving as PHY, but maybe leaning toward finding opportunities to target the regulation or sections of the law that are relevant via starting with the definitions and going from there. So maybe we can open up the public comment for this. I know we just came back from lunch, so maybe some people are not back either. But if there's any public comment related to this agenda item, we're going to open up for public comment just to start the discussion there. It's possible nobody's here, but let's try. Sarah, we're going to try to open up this discussion. Oh, thanks, Dr. Gray. See, he has his hand raised.
Yep, this is the moderator for members of the public on WebEx. If you would like to make a comment on this item, please click that raise hand icon, or if you're an audio-only participant, you can press *3 on your device. And Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. First, I'll say to everyone who doesn't know me, I'm old. Infusion center pharmacies started about 40 plus years ago when it was determined that patients were better off actually not being admitted to a hospital to receive IVs. And so pharmacies opened up that were outside the hospital, and they either dispensed them directly to the patients for home infusion, or they dispensed them to a medical office where the infusion was done, for an example, in an oncology center, not in the pharmacy, but maybe just across the hall or down the hall. And that's what we referred to. Now, when the ratios were set in the 90s, since it evolved from the hospital, the Board of Pharmacy took a policy that the ratio of a hospital applied to the infusion centers. And but they're not licensed as a hospital pharmacy, as was mentioned. And so in developing 405 2.2, which was collaborative practice pharmacy, but now called collaborative practice agreement, we added the term in there through the legislative process about patients that were part of a home health agency. Because at one point, what I just described, I think was you had to be part of a licensed home health agency. I don't know if that's true anymore or not. So, but it's a definite, and they needed the help. I mean, they needed more than a 1-to-1 ratio. They didn't fill a lot of these, but they might make up 5 bottles, back then they were glass, of oncology product or whatever at a time, and they did batches. So I think it does need to be clarified, whether it's a separate license type. That would be more clarity, but I think it needs to be clarified. But I think you need to be careful about the wording, because the infusion doesn't necessarily happen in the pharmacy where the compounding is made, etc. So, and I don't know that the people that run those would want the board to have jurisdiction over the whole building and everything. So I think that it could be supported and then clarified, and I think it would add to it. I think that I don't know where this is going, but I know the board was interested in taking a look at hydration centers and other things that use infusions. When I say infusion center, I'm talking about antibiotics or oncology products or products for organ transplant and so forth that are usually administered by a nurse and so forth. But the pharmacist working there, the close proximity is powerful. And the pharmacists actually take over managing the pain medications and the other medications for the cancer patients, as well as sometimes taking over the oncology products. Thank you.
Thanks for the comments, Dr. Gray.
All right, this is the moderator. Next, I have Devin Hood. And Devin, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device. And Devin, it looks like you're still muted. Let me request to unmute your microphone one more time.
Can you hear me now?
Yes, we can hear you.
Perfect. Hi, my name is Devin. I am a director of pharmacy for Optum out in Sacramento, California. We do home infusion. So this is just speaking from not for the company, but for me, that I think that it's beneficial currently just fusion would be for licensure versus changing it, because like Steve said earlier, for instance, we actually just deceased our acute operations, which was TPN and antibiotic therapy. But currently our branch not only does home infusion, but we have 2 seats or 2 chairs in our infusion center, which is licensed from the nursing board. But we have many patients that self-infuse sub-Q IG products. So I feel like that if we do a different, we wrangle or change the licensing requirements, that we may lose some elements such as patient counsel and some rights for patient safety if we don't handle this accordingly, because it is becoming more robust rather than just giving the meds to a nurse for them to infuse. And that's all I have to say.
Thank you for the comments.
All right, this is the moderator. Next I have Sam Martinez. And Sam, you'll be given 3 minutes to speak with a 10-second warning. Please click the unmute me button when the prompt appears on your device. All right, Sam, it appears we are not able to hear you. Let me request to unmute your microphone one more time. Oh, now we can hear you.
Thank you. Sorry. Hi, I'm Sam Martinez. I'm pharmacy manager at UC San Diego Health Infusion Center. And thank you for discussing this topic today, because I think it's important that we have a licensing that matches the practice. Most infusion centers are more closely related to hospital pharmacy, I would say, rather than retail pharmacy. There's things in the law that don't even apply to infusion centers, such as the font on the label, because the patient's not actually reading the label, the nurse is reading the label. The postings have been talked about before. And, there's a whole host of things that do not apply to infusion centers. So I think we could do a better job of still having the safety measures in place and making it more specific to the actual practice of pharmacy. Thank you.
Thank you for the comments, Dr. Martinez. I do have a favor for you before the full board meeting. If you could, any public commenters just provide in writing, specifying some of the sections of the law that you may feel is not relevant to the practice of what you are doing. So for the purpose of our discussion, that would be really helpful, because we are hoping to I think be more efficient in terms of regulations and for the regulated public to be able to provide the patient care. And so I'm hoping if you could those are great examples, and hoping you can put those in writing so that all of our members during the full board can review that when we discuss this in November 6th to be precise. Okay, with that, any other public comment?
This is the moderator. It appears there are no public comment at this time.
Thank you. Thank you for the comments. So with that, members, do we have any idea of what we want to look at? I mean, I think that this is a very early stage of the discussion, so we don't need to have any answers, but I think that we're just gathering information, seeing what would be the most possible way to kind of proceed. So it kind of is related. The agenda item 8 and 9 are kind of related. I'm sure you all follow that. So kind of thinking and just wondering if you're anybody with any thoughts on it. I know, Renee, you work with Infusion Center. I'm sure Satinder have experience, with Infusion Center. So please feel free to guide us in what direction you think is the right way to do it. Renee, go ahead.
Hi. Yeah, I do think this, again, like you said, as related to the other section, it needs clarity, right? There's confusion, there's overlap, and I think everybody's trying to do the right thing, but more information would be helpful as to what is, just as the previous commenter mentioned, a couple of instances. But I'm sure there are more. And then, it also is just to provide clarity, because it is an infusion center. So, I mean, sometimes they're being made on site, sometimes it's being shuttled over, and there's some, compounding implications with that as well. And wherever they are, I mean, they'd have to have a LSC, I'm assuming. So, but with that, I think just, again, more like a little more deeper detailed dive where, where there's overlap, and especially where there's not, but probably definitely a different license, because they don't fall under either of those.
Exactly. Any other thoughts, Claudia, Satinder?
Well, I don't know if we need a separate class. I think if we can get it more clarification within the regulations to maybe provide more guidance, so that it doesn't like it's sort of like you said, it related to previous comments, like if you say define it this, and then they don't have to do this kind of way, like it's practice side, maybe we can visit this in a similar way and create a more guidance for by defining it a little better and providing clarity.
Sounds good. So probably a lot more to come. I think we do need a little assistance from the regulated public in terms of what it is the pain point, as I stated at the beginning, of what it is that doesn't really make sense. I mean, more than honestly, and really, this discussion is being brought up because there are things that I think doesn't really make sense, right? It's kind of so I'm hoping to, streamline those and to make it. We do not want anybody to be in a situation of accidental violation of pharmacy law, right? And so we really don't want to be impractical. So I think Anne's example is good, the notice to consumers. And so hoping that we can further this discussion in our subsequent meetings and also to talk to the full board on our full board meeting in a couple weeks. Actually, 3 weeks. I'm sorry. Okay, Claudia, go ahead.
Yeah, and also can we add some information as to how many infusion centers are there being licensed right now? And also would like to understand like how big or how small do they usually operate? Can you have like
Sure, that I think is not something that we can probably provide as clear of an information. But Anne, I'm sorry, I'm punting to you. From my understanding, it'll be very hard for us to actually count the number of infusion center because they all are PHY or I think there are ways that HSPs, but it's mostly PHYs, is my understanding. We cannot hear you if you're there, Anne, in the room. Maybe Anne is not there. She just. Is there anyone in the room?
Can you hear me?
Oh, there you are.
Sorry about that. Yeah, with our current regulatory scheme, it's difficult to get to that number. And I think as like some were talking about, some of this might be happening outside of board licensed facilities. But so we've got kind of two challenges there in terms of getting you the what the volume or the quantifying the number of entities. If you were interested in getting an informational presentation, if that would be helpful, we can look to try to do that at a future meeting, if that would be helpful.
Yeah, I think that would be helpful just to understand their scope of work, kind of how they fit into the ecosystem, and then how do we support them and or understand in more detail how they operate so we can protect the public better.
Great. Thanks, Claudia. Okay, so more to come on this topic, obviously, and I think that what we'll probably do is to combine these two agenda item 8 and 9 into probably one topic in the future in terms of our committee discussion and maybe for the full board discussion. Any lasting words from our members before we go? All right,
I would just say, I was going to just
Claudia.
mention that I appreciated your point. Any public comments, if they can put them in writing, anything you want to share with us would be really helpful. So thank you for your time in advance.
Thank you. All right, especially the ones that are working in this space like Dr. Martinez and I think Dr. Evans, they're all working in this space. So it would be really helpful to give that information and share with the board members. Okay, moving on to the next agenda item 10. This basically is our last agenda item for the day. So this is discussion of application requirements for advanced practice pharmacist licensure, including possible action to make a recommendation to the board regarding proposed amendment to CCR Title 16, Section 1730.1. The meeting materials detail out the relevant sections of pharmacy law related to this agenda item. As noted in the meeting material, since implementation of the board's APH or Advanced Practice Pharmacist, now known as Advanced Pharmacist Practitioner, it's going to take us getting used to this licensure program, the board has performed post-implementation review to evaluate barriers to licensure. Given the scope of practice for an APA, I'm going to call it APP, APP expands beyond initiating, adjusting, and discontinuing therapy. It may be appropriate to consider if changes to the requirements in 16 CCR section 1730.1A3 are necessary to more broadly reflect relevant experience earned as part of a CPA in preparation for APHA license. I draw your attention to attachment 5 of the meeting materials, which includes possible changes to the regulation text, in addition to substantive changes reflected in the attachment. Non-substantive changes to update the title to advanced pharmacist practitioner will also be necessary. Members, any thoughts on this? Claudia, I know your hand is up, but it might be from the last comment. Yeah, okay.
I'm good, thank you.
It is really a minor simplifying change. I'm taking your silence as agreeing with the recommended changes.
Yes.
Okay. All right. With that, I guess, oh my God, maybe we are going to be not too late. We're ready for public comment. Sarah?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click that raise hand icon. Or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. I'll pause a moment to allow the public time to access these features and submit their requests. All right, looks like I do have a request from Sean Kim. And Sean, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you, board, for letting me comment on this item, advanced pharmacist practitioner. As you mentioned, it's going to take some time to adjust. We also have discussed this yesterday legislative town hall meeting, and there were some questions about this application process too. So we partly support the amending 16 CCR 1730.1A3 to streamline the collaborative practice agreement pathway and align licensure with the standard of care model and DPC 4052.6. The proposed language reduces the barriers for qualified pharmacists, especially those who could not or without the residency training and practicing in settings where formal CPAs or protocols are less in common. We encourage adoption of the following refinement to ensure the access and the clarity. Number one is the scope alignment. Recognize the APH relevant competencies beyond medication initiation adjustment. Explicitly include patient assessment, ordering, interpreting, drug therapy related tests, referrals, and collaborated disease management consistent with the 4052.6. Equity across settings. Allow experience obtain the standard of care authorities to qualify as CPA equivalent when pharmacists are performing APH level functions. And also we need to publish a template attestation, a brief FAQ that helps with competency map tied to the 4052.6 to promote consistent statewide evaluation. So these updates will support the APH adaptation and help address the care gap that occurs in California. So thank you so much for the opportunity to comment.
Thanks for the comments, Dr. Kim.
All right, this is the moderator. Next, I have Stephen Gray. And Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you very much. In reading through the regulation 1730.1, I think there are some ways that it could be clarified. There are probably 5,000 or 6,000 pharmacists in the United States that work for the Veterans Administration or the military that have all of the requisite experience. Many of them have Board of Pharmacy Specialty certification. And on top of that, they don't work under a collaborative practice agreement. They have what is called in the Veterans Administration an individual scope of practice that they were working under, and it changes from time to time. And when we developed the original collaborative practice language, we talked about that it didn't always require a residency if the applicant could demonstrate, equivalent. It called it direct patient care, but it really meant equivalent training and experience. So in going through that, I want to make sure that we're taking advantage of what's done in the Veterans Administration, the military, and other jurisdictions to give Californians the benefit of all that training and experience. There are some organizations, some of you may not know, but there are some large organizations that have several thousand of these AmCare pharmacists. Not all of them are APPs, but they never touch a drug. They manage high-risk patients on high-risk drugs better than traditional practice. Traditional practice is a euphemism of better than physicians. So, and it's been proven over and over again. So it's very important that we support this by making sure we're not accidentally eliminating very experienced, very capable pharmacists that could offer this service. Thank you.
Thank you for the comments, Dr. Gray.
All right, this is the moderator. It appears there are no further requests for public comment at this time.
Thank you, Sarah. Members, any comments after hearing from Dr. Gray?
I just have a small little question. When I was reading it, I came across this as 1 year of experience must include no fewer than 1,500 hours. That 1 year experience, is that in the statute? And then we further define 1,500 hours, or like I just seems like it's a little not clear.
Thank you, Satinder. I think from my memory, 1 year is in the statute and 1,500 is what the regulation added, but I think Anne or Corinne or Jennifer, can you guys comment on that, please? Oh, we don't hear you again.
So this is Anne. So in let's see, what section of the law I'm in? I think it's 4210. It says the specific section that I believe is relevant says has provided clinical services to a patient for at least 1 year. And so that's the statute, and then the reg is defining what that 1 year is.
Okay. Got it.
The
Thank you.
1,500 was from the historical perspective from the board when they implemented SB 493 back in 2014, 15 is when they decided that that's,
I vaguely remember, but I don't,
That's my understanding, but we can change it. This is open for discussion. So we're hoping this is just a starting point. Everybody's just, we can add or change. And I do think Dr. Gray does bring a good point. And I have to check with Corinne and Ann in terms of how we could allow pharmacists at VA who may or may not be licensed in California to be able to kind of help someone else to be an advanced pharmacist practitioner. Also, I just want to highlight that, through our statutory changes and through many of these discussions, I just want to highlight it is really important that advanced pharmacist practitioners can be a collaborative practice agreement holder. So there's nothing that restricts them from being a providing and creating a collaborative practice agreement. So I just think it's really important for our pharmacists to share this, that, as advanced pharmacist practitioner, which from our licensing data that I reviewed today, reviewed last week, but whenever the meeting materials came out, shows our number of advanced pharmacist practitioners has been increasing the last 3 years, which is really makes my heart very happy. So, I think we have about 60,000 pharmacists and about 1,400 are advanced pharmacist practitioners in the state of California. And I know our advanced pharmacist practitioner number 1 was on the call, Richard Dang. He's no longer, I think, on the call, but we've come a long way from that moment to, where we are. And I hope our pharmacists take full advantage of their advanced pharmacist practitioners to be able to really take care of our patient and provide the gaps in care. I know still we have long ways to go with AB 317 implementation, which requires the payment parity to at least allowing us to be a network provider. But I'm hoping that this kind of vision would allow our patients to have better access to providers. Our advanced pharmacist practitioners in many ways can provide excellent care in many of the disease states, conditions in managing drug therapy. So, all right, any member comments before we go? Okay, hopefully more to come. So as announced earlier, we're going to skip agenda item 11 as so much has changed. I do think that it would be beneficial for us to have a holistic discussion of kind of spot checking our surveys so that maybe we can have a better understanding of what's going on. Next, agenda item 12, discussion of licensing statistics. The meeting materials include a summary of the licensing statistics for the first 3 months of the fiscal year and 3-year fiscal year comparison data. This is my favorite part of the comparison data. So it really is great to review. You can see the totality, a trend, and also you can see all the number of licensed population in California at the last page. So it is very, very good information. Processing times for various facility business types vary, while few of the licensing programs are within the board's performance targets. Others exceed the 30-day target. But I know that as a quick reminder, the processing time noted in the meeting materials represent the oldest application of each type. The average processing time is lower. I just really want to shout out to all our licensing staff. They have been working so hard. I know Debbie Mitchell and all the managers are always working so hard to maintain these licenses, and they are super accessible to our regulated public. I do get great feedbacks. I know it's not always simple. So remember, PHY applications are very complex, but as you all know, we've updated our license form, license in the packet, the form, the pharmacy application form. And I'm hoping that that's helping licensees to be able to do better job of getting all the documents submitted. Overall, licensing statistics reflect 2% decrease in the number of individual applications received and 44% increase in facility applications received. This increase is primarily driven by changes of ownership for certain chain community pharmacy. The number of individual licenses renewed increased by 4%, and the number of facility licenses renewed increased by 3%. Any comments, members?
Yeah, I did want to point out.
Right, Claudia.
Yeah. So I did see that there's an increase in the wholesalers non-resident, and I think that's something that we talked about earlier, which is interesting. So I appreciate that data being here so that we can see those trends.
It's always interesting, yeah. All right. Anyone else? I just want to shout out again to all our licensing staff. They work so hard. Thank you to, of course, our executive staff, and we are ready for public comment. I know Sean had his hand raised really quick, but I don't know if he meant to do that or not, but I think we're ready to move on to, I think it's Dr. Gray.
This is the moderator for members of the public on WebEx. If you would like to make a comment on this item, please click that raise hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. And Stephen, you'll be given 3 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. Just a quick comment. I've been following the evolution or the non-evolution of the opening of remote site dispensing pharmacies since that category was created, maybe 10 years ago. I don't remember. And it was intended to hopefully address some of the pharmacy deserts by allowing a pharmacy to have a dispensing pharmacy that was staffed by pharmacy technicians, and then they were supervised by real-time audio visual by the host pharmacy. And that doesn't seem to have taken off very well. But maybe the reason is that if you look at the statute, it's very narrow who can have a remote site dispensing pharmacy. It's only open to a small category of pharmacies. That's the way the legislation was proposed. That's the way it was passed. So not-for-profit agencies cannot. Chain drugstores cannot. Now, which type of chain drugstore? You remember we have we have at least a couple of different definitions. So if the board is concerned about these pharmacy deserts, it may want to take a look at removing some of those limitations for example, government agencies are excluded from having remote site dispensing pharmacies. And maybe some of the counties should or would want to. And not-for-profit organizations, are excluded. So I would suggest maybe, give some thought to removing those restrictions, and maybe that more could help solve the pharmacy desert problem. Thank you.
Thank you for the comments, Dr. Gray.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. Okay, members. All righty, we are at the end of it. That is it. So future meeting dates and adjournment. Before we adjourn today, I'd like to thank everyone for your time and participation. Our next meeting is scheduled for January 8th of 2026. Good God. And I think October 7th, 2026 meeting will most likely be adjusted, but I think that's so far in the future. So we will have updates to that. The meeting is adjourned. Thank you everyone for your participation today. Thanks to members and our staff always for your time. Thanks for spending your precious Wednesday, almost 6 hours of all your hard work. And so thank you, and look forward to seeing you all in 3 weeks in Anaheim, and some of you tomorrow at Enforcement and Compounding Committee. Have a good day.
All right, see you later.